dignitaries that we have here today, the special guests, the guest of honor, and the chief guests that we have today here are some, I mean, though we do not need to introduce them, but very, very formally, very briefly, I'll just give you, because we already have many participants here, and the faculty stalwarts that we have, I think everybody has come to listen to them. And so it is, I'll do a very short, short introduction for my guests. So today I welcome and I'm thankful to Dr. Ragini Agarwal, who accepted this offer of coming here as the chief guest for this first webinar that we are holding in this new year under AOGT. So, can I have ma'am's CV, please? Dr. Ragini Agarwal, I would like to say that she is a leader who has a vision. Who, I mean, the vision cannot. I mean, we just, the way she gives us a path, a motto, and we just follow it blindly, and we come on to such very, very beautiful destinations with her guidances. She is an amazing person, a superhuman lady, a vice president Foxy 2020, a founder of many, many societies, Gurgaon Obs Gynae Society, her Obgyn, then IAG Haryana chapter, then ISOPAP Gurugram chapter, founder, president of Haryana Gynae Endoscopic Society, president Gurgaon Society, and she has a tremendous leadership quality, and I welcome Dr. Ragini ma'am to say a few words today to start with for us the webinar, please.
Thank you, Jyoti. Thank you for your kind words. Very good evening to all of you, and Happy New Year. And I pray to God that this year give us more positivity and a corona-free year ahead. Today's webinar, Jyoti, which you have planned, is amazing. The topic itself is very great because it should be discussed in a way, the way you are planned. Each and every part of adenomyosis is going to be discussed in detail with the stalwarts, none other than Ashok Khurana, Hafiz Rahman, a real living legend of the surgery, Dr. Asha Rao, and your
Ma'am, you've got muted. Please unmute.
All the chairpersons who are all stalwart in their field. And I can understand this thing that everybody is eagerly waiting to listen the stalwarts. So I will not stand in between. I will also ready to listen them. So all the best and happy learning to all of you. Over to you, Jyoti. It's really, really wonderful to be here on this new year.
Thank you so much, ma'am. My pleasure to have you here on this platform and take your blessings. Coming on to another beautiful lady, a person who is as amazing as her name, Lakshmi. Lakshmi is something everybody loves. So Lakshmi is something, I mean, I don't think there would be any person who would say, I don't like Lakshmi. So that is what our guest of honor is today. And may I have her CV? Yes, she's Director Shri Khande Hospital, Nagpur, a chairperson ICOG, designate ICOG patron and president ISOPA Vidarbha chapter, associate member of ICOG and ESHRE. And she is delivered so many orations, so many lectures. And I welcome Dr. Lakshmi, and I wish, I mean, we have all seen you every day on some webinar or the other. So welcome, and we would like to have your blessings here.
Thank you so much, Jyoti, for your invitation and your kind introduction. Very good afternoon to all the dear faculties and the delegates, and I wish you all a happy and healthy 2021. My friend Ragini has already told the importance of the topic, and she has already praised all the 4 subject experts. Friends, when a woman comes with adenomyosis and she is around 50 plus, she wants hysterectomy, the life becomes easier for all the treating clinicians. But in this 21st century, where the woman also wants to conserve her uterus, and we all, as a Foxian, our motto is also to save the uterus. We don't want to do the hysterectomy where it is not needed, where it is not indicated. And when this woman wants to have a child, this poses a very special challenge for the fertility specialist. So I'm so happy, Jyoti, that you have kept only 4 topics which are very relevant to the practicing clinician point of view. The diagnosis, yes, very important to differentiate it from fibroid. Medical management, surgical management, yes, I am sure apart from removing the uterus, there are many uterus sparing surgeries and infertility management which you yourself are delivering. So I wish you all the very best, and I'm sure all the delegates will take practical take-home messages from all the speakers who are experts in their subjects. They are very well experienced in managing adenomyosis. So I wish you all happy learning and all the very best to the organizers. Thank you, Jyoti, once again for inviting me here.
Many, many thanks, Dr. Lakshmi ma'am. It was very kind of you to, though you are holding your annual international ISOPAB conference and very, very busy, but thank you for accepting this offer to be here today for some time. Thank you so much again. And coming on to our third special guest, Dr. Achla Batra, who is the president now from maybe this session in 2021 of AOGD. AOGD, a very big and a very, very important organization of FOGSI, the Association of Gynecologists of Delhi. So Dr. Achla is professor, unit head, a very senior consultant at VMMC and Safdarjung. She was President NACI, Honorary Secretary AOGD in 2015-16, Editor-in-Chief AOGD in 2008 and 9. And this year we will see so many things, so many webinars, so many academic things coming under her leadership as a President-elect of AOGD in 21-22. And I welcome Dr. Achla ma'am, and I wish to hear some blessings and invitational words from you, Dr. Achla ma'am.
Good evening, and thank you very much to beautiful and charming Jyoti Malik for making me part of this webinar. This adenomyosis is an enigmatic disorder, and everybody has talked so much about. The speakers are going to do justice to it. Very good speakers. So I think we are going to learn a lot from them. From whatever we know, I think when we learn from the expert, we always get to know something, and I hope we'll have some good interaction also. And I think I should not keep you away from the webinar now. Thank you very much.
Thank you so much, Dr. Achla ma'am, for joining us today on this platform here and giving us the blessings. Over to Dr. Richa for starting the session, please. Dr. Richa, unmute yourself. Unmute yourself.
Good evening and warm welcome to all the faculties and the participant today. And today we'll be learning A to Z on adenomyosis. And we have the renowned faculty, as it has been discussed again and again, and they will share their experience and the knowledge. And as everybody know, today's webinar is being organized by the Dr. Jyoti Malik, and actually she has left no stones unturned for its success. And my best wishes for a successful webinar and happy learning to all the participants. So now we move on to our first session, and can I have the CV please? So we move on to our first session, and Dr. Ashok Khurana, he will be speaking on diagnostic modalities in adenomyosis. Mr. Rajput, can you put up the CV? So I invite the first chairperson. Dr. Sonal Panchal. who is the consultant at Dr. Nagores Institute for Infertility and IVF. And she was a professor of Dubrovnik Institute University and faculty at Ian Donald School of Ultrasound and Master Courses at Dubai. And she is also a National Academic Director, Ian Donald School of India. Welcome, Dr. Sonal Panjal. Then next chairperson is Dr. Rajendra Nanda. Dr. Rajendra, he is the medical director and HOD of Nanda Diagnostics at Delhi. And he is the alumnus of MAMC and has 32 years of experience. So now I request Dr. Rajendra to please introduce Dr. Ashok Khurana.
Hello, everybody. Now I invite Professor Ashok Khurana for a talk on diagnostic modalities in adenomyosis. Dr. Ashok Khurana is an alumnus of All India Institute of Medical Sciences and got further training in ultrasound at Herlev Hospital in Denmark. He has many firsts to his credit. He is chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi. He is the Professor, School of Health Sciences, Dubrovnik International University, Croatia. He is the past president of the Society of Fetal Medicine. He is the ISIOG ambassador in India. He is the editor-in-chief of Journal of Fetal Medicine. He has already inspired 2 generations of ultrasonologists. Welcome, Dr. Ashok Khurana. The floor is yours, sir.
Thank you. Thank you, Rajendra. That was very, very kind. And it is indeed a pleasure to be amongst friends. I will go on to share my screen and we go right ahead with this presentation. I'd like to take this opportunity to thank the AOGD Endoscopy Committee and also Dr. Jyoti Malik for putting this together. I'm also very pleased that we now have an AOGD multidisciplinary committee, and we're discussing this afternoon the Understanding and Treating Adenomyosis, and I will discuss the diagnostic modalities. I do hope you can see my screen share and that I can be heard.
Yes, yes, sir.
Marvelous. So there we go. Diagnostic modalities in adenomyosis. Basically, I will go through definitions because it's the start of the session. Present the diagnostic modalities and the ultrasound features in particular, then reporting systems that have now come into place. And I like these because they put us all on the same page. We realize that we live in an era of super specialization and expensive equipment. So some of us are better at imaging, some of us are much better at surgery and so on. But because we all ultimately owe something to our patient or a lot to our patient, we really need to be speaking the same language. So I will discuss reporting systems. We will also go through the current status of MRI in the evaluation of adenomyosis, and I'll throw in recent advances as we go along. It is a changing field, but what has not changed is the definition. And adenomyosis has been always recognized as a gynecological condition, which is characterized by ectopic endometrial tissue within the uterine myometrium. This is an image from Rokitansky and his presentation many, many years ago. And from there on, we moved on to understanding pathology and transferring it to images like this, which clearly delineate that we can see everything that's going on in the uterine wall almost as well as the pathologist can. In fact, the interesting thing is that histopathology is truly no longer the gold standard, and there is a reason for this. If I were to sample my uterus incorrectly, say at this level here, where you see my arrow or something like this, I'm going to miss out on this patch of adenomyosis correctly. So even the pathologist might miss out on dilated endometrial glands and muscular hyperplasia, as you see here, and miss this diagnosis. So we must understand that we have to work hard with a pathologist with images like this to make sure that we get the diagnosis correctly at the end. We've had different names for adenomyosis. Some people like to call it endometriosis interna, uterine adenomyosis, and cystosarcoma adenoids uterinum, none of which is in place now. We call it adenomyosis. It's a phenomenon within the uterus, and we shall always refer to it as that. Now, The histologic diagnosis of adenomyosis is by looking for endometrial stroma and glands in the myometrium. That means it's a diagnosis on a hysterectomy. Now, that's not something we need to do. Also, there is no consensus among pathologists, and we've had many definitions, including disruption of the normal boundary between the endometrium and the myometrium, the presence of ectopic endometrium that is basal type, non-secretory, with a direct connection to the basalis layer, various degrees of myometrial invasion by the endometrium in terms of millimeters and percentages, but the fact is that there is no consensus, and therefore you and me need a consensus which is non-post-surgical, and we have to discuss the same thing. One of the recent presentations that we had on this was by the Lazzari group in 2018, which they published in Fertility, Sterility, and this is from the large group, including Tom Byrne, who've been working on this for the past 2 years. But do take a look at this. It has a beautiful description. It's very mathematical. But would you and me ever use this in daily routine? Of course not. I mean, I have better things to do than sit and add up things like this and say, oh my God, so how much is the score now? And therefore, should I operate, should I not operate? Certainly not. I would never operate on the basis of a score. What I need is to give a description so that my clinician can then follow this up. And I need something like this. I need a series of ultrasound features, which I learned to recognize, such as the contour of the uterus, the definition of the lesion, ill-defined or well-defined, the symmetry of the uterine walls, the shape of the uterus, the contour of the uterus, shadowing within the walls, echogenicity, vascularity in the endometrial rim, and therefore I should be able to differentiate between a diffuse adenomyosis, a focal adenomyosis, and an adenomyoma. That's the kind of thing I need, and that's what we're going to discuss. This is a descriptor from the same paper, but it does move ahead to a point where I can actually use it in everyday life, and I'll show you how we use it. The two things that we always look for, of course, are the adenosis and the meiosis. The adenosis results in ectopic endometrial glands and stroma, which correspond to echogenic striations or nodules on ultrasound, myometrial cysts, and cystic striations. So this is what we see on ultrasound. And then you have the meiosis representation, which is the muscular hyperplasia or hypertrophy, as some people prefer to call it, which is the thickened inner myometrium. And you have a myometrial thickening, focal or diffuse. You have an enlarged globular uterus and a pencil thin Venetian blind, which I will be showing you. And this results in that patchy uterus as you see it here. And that's also called cirrhosis of the uterus, a word that we no longer use, but pathologists like to use that. We also have looked at myometrial vascularity with ultrasound, and we know that we have increased vascularity in penetrating vessels, unlike fibroids. So if you have a focal lesion that has vessels starting at the center, not too much peripheral vascularity, this combination is classical of an adenomyoma, and therefore we are able to recognize it. And this is what I will discuss over the next 15 minutes. Very important to discuss that there are three different situations. There is a focal adenomyosis, there is a diffuse adenomyosis, and a focal adenomyoma. In a focal adenomyosis, the rest of the myometrium is almost normal. You have a circular lesion here, but when you measure the wall on this side and you measure the wall on that side, it's more than 25% of the circumference of the lesion, and therefore then we call it a focal adenomyosis. On the other hand, if you find this degree of cysts as well as non-cysts as well as echogenic plaques, as we call them, then you say, okay, it's a diffuse lesion. Then I know that I'm looking at a diffuse adenomyosis. And if I look at an almost encapsulated lesion, heteroechoic, with vascularity throughout it, which I will show you, then I know we're looking at focal adenomyosis. Essentially, this is the appearance we're looking for: focal adenomyosis, a diffuse adenomyosis, and the adenomyoma. There is a very nice article on all of this, which has come out in the UOG May 2018. And I suggest you see this. It's by Van den Bosch, for those of you who like to correlate things surgically, and it will help you also to get a great understanding into what adenomyosis is all about. What we look at is a globular uterus, which means that it is wide in the transverse and anterior posterior diameter compared to the length. You can get an asymmetric thickening, and usually it's the posterior wall that is more thickened than the anterior wall. You can get cysts within the wall, and these are actually active endometrial glands. You can get echogenic islands or hyperechoic islands, and these are more frequent in the posterior wall compared to the anterior one. Or you can get this fan-shaped shadowing, which some people call the Venetian blind shadowing. And these are artifacts that arise as the beam passes through an echogenicity of, when the beam passes through a myometrium that interrupts the echogenicity. Remember that you can get lines coming out, and we will discuss this as we go along. You can get translesional vascularity and an irregular or an interrupted junctional zone. And now that you have your theory in place, let me show you what this looks like. So the globular uterus is truly globular, it's very, very round, and you get to see it more and more on ultrasound the more you look for it. Asymmetric thickening, and you can actually measure this portion of the wall and compare it to this back portion of the wall. You find anechoic areas with very bright walls, and those are the cysts of adenomyosis. You can get these, which are the hyperechoic islands, as you see here, and there might be a few or there might be many. And then, of course, the fan-shaped shadowing that you see here. All classical signs. Now remember, not any one of these signs by themselves will be conclusive for adenomyosis. There is a slight overlap because whenever there is interruption of the myometrium, this can happen, but largely each one of these represents adenomyosis. But again, the degree of adenomyosis seen on ultrasound does not always correlate with the symptoms of adenomyosis. Also with adenomyosis, you can have associated lesions such as polyps, such as fibroids, and such as infections, or even a carcinoma. And therefore, you don't stop looking when you look at these, you look at everything, and of course, you look at the adnexa as well. The other findings on the right side are better seen in coronal view and best seen in a 3D view or with power Doppler. And 3D power and 3D views give us a very nice, clean margin to look at compared to this margin, which is adenomyosis. And they also end up showing lines like you see here and buds like you see here. Very distinct, very easy, and this kind of technology is now available in most ultrasound units. Translesional vascularity like this one, odd margins at the periphery, but lots of central flow, and this is the classical sign of an adenomyosis or an adenomyoma, both. And then an irregular interruption of the outline of the endometrium with loss of a junctional zone, which we will discuss. And all of these are signs of adenomyosis. So this is what you have to tune yourself for, and therefore it's nice to remember that there is a whole plethora of signs which we like to look at. Remember that transabdominal scans may be useful if the uterus is very large. Transvaginal scans are what we routinely use, and we invariably combine them with either power Doppler or directional power Doppler, and sometimes even slow flow, which will show things like you see flow around a myometrial cyst here. And slow flow is necessary because a lot of flow in the pelvis is very slow, 0 to 5 centimeters per second. And then you can combine it with 3D to be able to see 3D vascular morphology to differentiate from a malignant process. 3D without vascularity is also important. For instance, here you see these striations coming out, interruption of the myometrial endometrial junction, a little bit seen here, but most of it missing. And remember that you can see some of it on 2D. You can see a lot of it on the newer 3D rendering engines, as these are called. And you may not see it on the old 3D images as well as you see them on the newer ones. So it's nice to make sure that your technology is new and that you always combine it with vascular information as well. And we will at the end discuss magnetic resonance imaging as well. Now, what do these things look like on 2D? Well, you can pick up the echogenic subendometrial lines like these fine ones here. But as you notice, I've actually had to draw arrows to point these out because they're not always so prominent as you see on a coronal view done on 3D. The same thing applies to echogenic subendometrial buds. You can see only pegs on 2D, and you saw how nicely we were able to see these on 3D. And hyperechoic islands, of course, can be equally well seen on 2D as well as 3D. And so this is what we like to look for. And we look for each one of these in detail so that we can have a final diagnosis. Remember that cysts are very common, and you can have a lesion which has no cysts, and you can have cysts which appear as circumscribed lesions with a bright wall, and they're usually very vascular throughout the cycle and far more vascular at the time of menstruation, of course. So within an area which is speckled like this and which is giving all those artifacts, the fan-shaped artifact, you can also find cysts, and you can find in between some of those echogenic islands and some of those lines coming off like you see over here. So it's always the combination, And then you correlate it with the coronal view and see, yes, it's a shaggy outline, interruption here in the fundal area, which corresponds to this area here. And therefore you have a full diagnosis, and you always combine it with the presence of translesional vascularity, and you have a final diagnosis sitting there that this is not a fibroid in this region, this is not a fibroid in this region, this is focal adenomyosis, and to some extent a diffuse adenomyosis as well. The location of the lesion is important because this helps a lot in surgical mapping for a lesion in case you're planning surgery which is limited, or in case you're taking the option of expectant or medical management. And then we divide the entire myometrium into a subendometrial layer, which is called the inner myometrium, the main bulk, which is called the middle myometrium, and the outer one, which is a subserosal layer. And we like to define whether the lesion is largely in the inner, the middle, or the outer one. And remember that, again, you can have associated fibroids. It is nice to give standard names to these, but this classification has not been very widely accepted yet. And so I will skip it for now. And maybe in a year or two, when it gets accepted, we will discuss that in detail. There is a recommended reporting, again, from the same group that gave us the 2018 paper, which says that you will mention the location of the adenomyosis, anterior wall, posterior wall, left lateral, right lateral, or fundal. You'll have to make sure whether you mention focal and diffuse, or just diffuse. And then, of course, define the adenomyoma. The presence of cystic versus non-cystic adenomyosis. The cystic is definitely more symptomatic than the non-cystic. The degree of uterine layer involvement, whether it's the junctional zone, which is the inner portion, the middle myometrium or the outer, and the extent, whether it's 25% of myometrium or less, 25 to 50, or 50% of the entire extent of the myometrium. And then, of course, if there are focal lesions, we mention the size. So this kind of report is what the treating surgeon or the treating clinician would expect from an ultrasound report. Now, do remember that some of these things, particularly on machines that are medium end, may not show up so nicely. And the quickest and most convincing way to see it is truly 3D. And with the newer rendering engines, you have the 3 layers very well defined. This is the endometrium here. You have a subendometrial layer here, a middle portion of the myometrium, and a subserous layer here. Adenomyosis with stranding of echogenic endometrium into the entire inner and middle portion, as you see here, part of the wall well defined here. This is so-called mild involvement. Here it spares the left wall completely, but fairly extensive involvement of the right wall and the frontal aspect. And this is a severe adenomyosis with completely obscured cavity, with pegs and patches all extending into the whole myometrium. So this is how easy it becomes when you have a newer engine rendering with 3D ultrasound. And believe me, it takes just a few seconds to get an image like this. Equipment costs money, but when we have a large number of patients, we tend to break even on the costs. Also remember that laparoscopy is not always the gold standard. And I like using this slide often. On laparoscopy, I see a broad fundus, and the first thing I would think of is that this is adenomyosis, and sure enough, it turns out to be that 8 out of 10 times. Occasionally, you can have a broad fundus, but it consists of a septal fibroid inside, which you might spot on a hysteroscopy, but you won't spot it on a laparoscopy. Again, you could have one well-developed cornu, and in the other cornu, you can have a fibroid and you have a broad fundus. And therefore, 3D becomes a very important tool for pre-surgical mapping. Here, for instance, a cavity which is okay in shape, but displaced by a large fibroid. And if she had a failed IVF, I would think of an alternative for this lady before we have another failed IVF. Or here, where hysteroscopy might show you one fibroid bulging on the surface, but only ultrasound will show you that there are 2 fibroids sitting over here. Then, of course, this kind of an image where you have a thickening of the wall. The most classical image, which is usually well apparent on 2D, where the anterior wall is not thickened and the posterior wall is thickened. And depending on the extent of involvement of the myometrium, you will find a well-defined outline of the endometrium, or you may not. So it might be partially seen, partially obscured, And one of the greatest indicators of adenomyosis always is a measurement of the transverse diameter of the uterus. So the transverse diameter of the uterus typically would be far in excess of what we expect. Normally, we would expect the adult uterus in the menstruating woman to be about 5 centimeters. And usually in adenomyosis, it is more than 5 centimeters. Remember that sometimes you can't even see anything of a endometrium, and then it's just a question of obscuring by the fan-shaped artifacts and this intense adenomyosis and cysts sitting in the anterior wall. And then again, you have to start looking for 3D clues, because you must identify somewhere in there that there is a cavity that looks like this. It might be pushed to one side, and you really have to work hard to try and identify it, because then you get to define the lesion far better. Remember that this ill-defined hyperechogenic stuff is usually heterotopic endometrial glands, and the hypoechoic areas you see in between is smooth muscle hyperplasia. And then, of course, the cysts are always seen as anechoic area. So this is your typical severe adenomyosis that we get used to. And like I said, if you see a nice outline, remember, it may not be as good as you see on a 2D, because 3D clearly shows that there's a huge amount of adenomyosis extending all the way throughout. Remember that we don't use low frequency transducers, and we use at least a 7 megahertz transducer, and preferably a 6 to 12 megahertz transducer to produce images like this. The islands are also sometimes known as cobblestoning, because this is what they look like on 3D. And in this situation, it is very difficult to talk about endometrial thickness. And therefore, you have to be very careful that in a patient, for instance, who is perimenopausal or immediate postmenopausal and she has bleeding, it's very difficult to assess endometrial thickness. And very often you describe a thick endometrium because you presume this is all endometrium, but this is actually all adenomyosis. And the histoscope shows a bald endometrium or a bald cavity. So this is something that you truly need to be aware of, that adenomyosis can mess up endometrial thickness evaluation big time. Also, that the anterior wall might be sometimes thickened and not just the posterior wall, as you see here. Anterior wall and posterior wall non-thickened, and here I'm pushing it to see whether there's any tenderness. So that tenderness would say, yes, this is the pain I get during menstruation. I know it's because of adenomyosis. And sure enough, the uterus is full of adenomyosis. You see the lines, you see the patches, and you know for sure you're looking at adenomyosis. Remember that almost all of these, when you have a focal lesion, excuse me, you will find when you compare it to a fibroid, it's usually elliptical rather than globular, poorly marginated. You will not have rim vascularization like you find in a fibroid. You have a spoke wheel vascularization. Adenomyomas are rarely calcified. Fibroids are frequently calcified. The mass effect is minimal compared to the size of an adenomyoma. Fibroids have a large mass effect. And then you always have associated lesions within the rest of the myometrium that tells you, look, think of an adenomyoma, don't think of just a fibroid. Color always clinches the diagnosis in this situation. And this type of a burst of color from the center of that lesion will tell you that you're looking at an adenomyoma rather than a fibroid. Do also remember that sometimes you can have a poorly defined lesion, a cystic area, and then you start wondering, is this degeneration or not? In this situation, MRI is helpful because adenomyotic lesions are usually full of blood and give a classical hemosiderin hyperintense signal on MRI when you do T2-weighted images. So when you're confused on a situation like this, is this a fibroid with central degeneration? Is this an adenomyoma? An MRI would be useful in that situation. And like I said, remember that you have to be very careful when you look at a poorly marginated endometrium. It could just be either the adenomyosis, or if you put on color, you might pick up that, look, this looks a little more bizarre than I'm comfortable with. And if this looks a little more bizarre than I'm comfortable with, what's going on? I do a 3D vascular reconstruction and I find sitting here a malignant polyp. Once upon a time, we used to routinely put fluid into the cavity of the uterus to try and delineate the endometrium, but that does not help. The contrastiness of 3D ultrasound without using radiological contrast is truly what we use today. And so this is one thing I always like to point out, that look, when we have an adenomyosis, you always have an overassessment of endometrial thickness. Also, you might miss an early myometrial invasion in an endometrial cancer, and so be very careful and always do 3D, it might help you. That adenomyosis and an endometrial cancer can coexist, and therefore it's not always the final word, and you have to keep an open mind. And that myometrial cysts in the outer third are often not adenomyotic, and color Doppler will then confirm myometrial veins, because you will take a signal from them, you will take a spectral Doppler from them, and you will get an answer. Which brings us to MRI. Now, MRI has lots written about it, but the important thing is that, of course, you will see a hypointense lesion on T2-weighted images for the whole thing, a low signal intensity. The important thing is to look for hemorrhagic foci, and these appear as spotty signal voids owing to the T2 shortening of hemocentrin, and that's how you pick it up. And there used to be this statement, which always was, that if the junction zone is more than 12 millimeters, that's adenomyosis. That doesn't hold true anymore. And the other thing is that a lot of people in radiology don't have time, unfortunately, for looking carefully at gynae scans, and they take a lot of effort compared to scans of other areas. And therefore, we have very few radiologists who take interest in this. And therefore, all over the world now, we realize that a transvaginal scan with Doppler and with 3D compares beautifully, if not better, with MRI. Of course, the tragedy is that sometimes ultrasound is not well done, then you're really stuck. So it might be worth it sometimes when you're doing your own ultrasound scans to get a second opinion on a high-end machine and try and get this information from a second ultrasound, rather than fast-tracking these patients to MRI. These are some MRI images, and here is the graphic representation. A huge amount of adenomyosis around the cavity, focal adenomyosis, a cyst sitting here, an adenomyomatous polyp sitting here, and then of course lesions on the surface, both at the back of the uterus and the front of the uterus. Typical lesion, hypoechoic, around the cavity, wall thickening. In this case, this was posterior wall thickening. You can see it's an anteverted uterus, so this is posterior wall, and then this shaggy appearance, and then of course odd bright bits, which is the classical hemocentrin signal. So to conclude, the introduction of imaging techniques such as TVS and MRI has allowed a non-invasive diagnosis of adenomyosis, which so far was called an enigma. Ultrasound is widely available in the office setting, relatively inexpensive, requires no preparation, no contraindications, no radiological contrast, and in expert hands, it becomes the modality of choice. Also to remember that patient management is often based on ultrasound diagnosis alone, and therefore we need a uniform, reproducible, and clinically relevant reporting system for ultrasound findings of adenomyosis, which is why I presented these. And uniform reporting will also facilitate studies on prevalence, etiology, and clinical implications of adenomyosis, and on the effectiveness of non-surgical therapies. So like a follow-up ultrasound scan. Thank you so much for your attention. Let me summarize by saying we look for asymmetric thickening, cysts, hyperechoic islands, fan-shaped shadowing, the globular uterus, subendometrial lines and buds, translesional vascularity, irregular or interrupted junctional zone. Thank you indeed.
Wonderful lecture, Dr. Ashok Khurana. Do we have some questions?
I think there are no questions just now in the chat box.
Okay.
But
then I would say that that 2D, 3D ultrasound and the MRI, they all perform the same as far as the diagnosis of adenomyosis is concerned. But 3D ultrasound is particularly looking for junctional zone interruptions and irregularities. But a word of caution that 3D ultrasound is very user dependent and there can be a lot of artifacts. So you really need some experience before you start diagnosing adenomyosis on 3D ultrasound. Similarly, in MRI, you need a very good protocol and an experienced radiologist to diagnose adenomyosis on MRI. So TVS, 2D ultrasound and 3D ultrasound should be the first line of investigation, and MRI can be used in cases where there is a doubt. Now there is a question of that how many features are essential to diagnose adenomyosis. Like Musa group gave us 9 features, out of which if you pick up hyperechoic islands, subendometrial lines and buds, and myometrial cysts, these are the primary features. And even if you have 2 of these features, that is diagnostic of adenomyosis. These are also a direct sign rather than the indirect sign where you have globular uterus or asymmetrically thickened uterus, transrenal vascularity. These are the indirect signs of diagnosing adenomyosis. A wonderful talk, Dr. Ashok Khurana. It was a very inclusive talk. You took care of all the aspects of adenomyosis. Thank you.
Thank you.
Thank you, Dr. Ashok sir. It was really a wonderful and crisp talk. And thank you, Dr. Rajinder, for all your valuable inputs. Sir, I just wanted to ask one thing, like few patients, whoever come for 2D scan, and how often or which patient you had to do 3D scan also to confirm before
Question actually for the past every gynecological scan without 3D. Every single gynecological scan has by definition Doppler as well as 3D. And I firmly believe that there's so much information in every gynecological condition. And the fact that we are actually going to be treating a lot of the times the ultrasound picture rather than the patient's presentation. Therefore, we really need to be not leave any stone unturned and make sure that we give enough information for this decision to be taken, because there is just too much at stake. So there is no question of saying advise 3D scan. I firmly believe that every gynae scan has to be a 3D scan.
Yeah, that's I definitely agree with you, Dr. Khurana. And whenever you diagnose adenomyosis by ultrasound, how often have you asked for MRI?
I never ask for MRI for adenomyosis.
I love that.
I make sure that I will place that uterus
so much for saying that.
till I get an answer.
Dr. Khurana, do you think the incidence of adenomyosis has increased, or we are diagnosing it properly? Because earlier we never heard of so many cases of adenomyosis, and these days, at least in our infertility clinics, we are seeing a huge number of these cases which have increased. And thanks to your lecture today, it was an eye-opener. You know, though we are doing regularly the color Doppler, but then I think including the 3D is important. And what is your view? Really, are these cases increasing?
Yeah, no, we're just picking it up a lot more. So we were dumping them all as unexplained infertility, but here we know that we have a uterine factor that contributes. Our resolution has increased so much with the newer transducers, and the degree of contrastiness, normal myometrium versus adenomyotic myometrium, is much better picked up with the new high frequency transducers. So we're actually identifying it much more. I don't think that the incidence is much more. You know, when we used to do PVs on all our patients, I remember even before doing a gynae ultrasound, I used to do a PV. We used to feel that, look, this feels like an adenomyotic uterus. And we never used to find anything on the ultrasound except bulky uterus. And that was because we didn't have the capacity, the technology to see this. Today we do. So now I don't even do PVs, I just do a sono palpation and a sono evaluation.
Thank you.
Wonderful, sir. That was amazing. Always as usual.
Thank
Always,
you, Jyoti.
you make such a difficult topic so very easy. And I mean, that is why we call you the Amitabh Bachchan of ultrasound, I suppose. So,
Thank you, and thank you for this opportunity. It's very kind of you.
Okay, so moving on, now I would invite my next set of chairpersons. We have Dr. Shashilata Kabra Maheshwari. She is the AOGD Multidisciplinary Committee chairperson, and she is also the PPH lady. I mean, the way she is working for internal ligations, teaching people all over Delhi and India, I think that is amazing. And I think can I have her the CV of Dr. Shashi so that I can just briefly go through the and she recently.
Meenal.
Yeah, 1 second. So actually, she has been into lots of committees of FOXY, a food drug committee, the breast committee, safe motherhood committee, and she has received various awards. IMA Appreciation Award, has been on editorial board, member of PPMPL, Journal of Obstetric Gynecologic Research Committee, and a chair recipient of Wonder FOXY Award, NBE faculty and resource person, chairperson that she has recently, this multidisciplinary committee that has come up. So she is going to make us be more on our toes this year with her chairpersonship, doing so many more webinars there. And she is also a chairperson of PCPD and PD Committee of West District Delhi, a national mentor of Lakshya Project in association with AIMS and Delhi GOI WHO. So welcome, Dr. Shashi, and thank you for doing this under your committee, the webinar. And then I would have another Wonder Woman who has done so much proud to Delhi. May I have the CV of Dr. Mala Srivastava, please? So Dr. Mala has done a roller coaster. Her tenure was like that. The way she has taken the AOGD during her tenureship as a president of AOGD was absolutely commendable. And thank you so much, Dr. Mala, for being the president and doing so much work in this AOGD in 2021. So she is a gynec-onco, gynec endoscopy, and a robotic surgeon, a senior consultant, and she is presently a robotic surgeon and an endoscopic surgeon at Sir Gangaram Hospital, New Delhi. So over to the chairpersons, please. And I think I can request Dr. Kabra to please introduce our next worthy speaker.
Thank you, Dr. Jyoti. Thank you for such a kind introduction, and also for doing this activity under the banner of Endoscopy and Multidisciplinary Committee. So, and I'm very happy to share this chair with our most respected Mala Srivastava ma'am, who is the President AOGD. And I take immense pleasure in introducing Dr. Asha Rao. She is our next speaker. She is the past president of Coimbatore OBG Society 2017 and 19, and is the organizing chairperson of UA FOXY South Zone 2019, organizing chairperson IEG Star Endogynec Conclave 2019, and recipient of President of India Gold Medal and Postgraduate in Gynecology from Stanley Medical College, delivered first ICSI baby of Coimbatore in 1998 and first vitrification baby of Coimbatore in 2008. She is also the chairperson of Endometriosis FOXY Committee 2020-2022. She is a stalwart in the management of endometriosis, and she will enlighten us about the new paradigms in medical management of adenomyosis. So over to you, Dr. Asha Rao. The stage is yours now.
Thank you so much, Shashi, for those kind words. And at the outset, let me thank Dr. Jyoti Malik, the brilliant lady who has organized this wonderful webinar, for having invited me here. It has always been, adenomyosis is always my passion. And thank you so much for having given me the chance to speak on the management of adenomyosis, that too medical management. Let me start sharing my screen. And it was such a lucid talk by Dr. Khurana. He has made so many points very clear. Adenomyosis, the disease which was diagnosed historically by histopathology at hysterectomy, today is being seen more and more in younger women. The disease which was considered typical of women over 40 years and multipara is seen in younger women and also seen in about 20% of women less than 40 years undergoing ART. My first introduction to adenomyosis, I could say, was in 1993 when I saw this lady who was 34 years and married for 16 years. I mean, she was married at the age of 18 years. So she was now married for 16 years. She had severe dysmenorrhea, no male factor, bilateral tubal block. We did a hysterolaparoscopy and we tried doing a tubal cannulation, but we could not release the block. We diagnosed a cornal block, uterus was 12-week size, and we had nothing but danazol those days. We gave her danazol for 6 months. She enjoyed the pain-free period. And at the end of it, when she stopped the danazol, she promptly conceived. And this child born in 1993 got married last year. So it was such a wonderful, happy occasion to see that daughter get married. And this is how my journey into adenomyosis started. Typically, the symptoms of adenomyosis were said to be menorrhagia and severe dysmenorrhea. But today, infertility and reproductive dysfunctions have been added as also the symptoms of adenomyosis. So whenever somebody has recurrent implantation failure or recurrent pregnancy loss, severe bleeding, one should definitely look for adenomyosis. I would say that the diagnosis is better. At the same time, perhaps incidence also is marginally more because of women postponing their fertile years from 20s to late 30s. We do not have exact diagnostic modality apart from ultrasound and MRI. And we cannot do a tissue diagnosis. But we know that 54% of young women with infertility, dysmenorrhea, and menorrhagia could be having adenomyosis. And 28% of subfertile population has adenomyosis alone. And 21% of women with endometriosis concomitantly had adenomyosis. And adenomyosis is also associated with fibroid. And it's also one of the important members of palm coin group of etiologies for AUB. And whenever there is a failure of conservative management of AUB, one should definitely suspect adenomyosis. The complex pathogenesis and variable presentation of adenomyosis make it one of the most difficult of the palm coin etiologies to diagnose and treat. We know that it can be focal and diffuse. It's a disease of the junctional zone. You can see the junctional zone is barely 4 to 5 millimeters during the reproductive years. And whenever Dr. Khurana has told us a lot, so I need not go into the details. It is a disease of estrogen dominance, which leads to Th1 type of inflammatory type of reactions, increase in the COX-2 levels, prostaglandin E2, vascular endothelial growth factors, matrix metalloproteinases, and increase in the anti-apoptotic factors, increase in aromatase activity, etc. And all of us know that the etiology could be heterogeneous. The invasion of the endometrium into myometrium can also happen as a result of autotraumatization and tissue injury in the myometrium, which is peculiar to some women, perhaps because of the genetic predisposition or because of increased levels of estradiol there, because of the increase in aromatase P450 cytochrome. So this local hyperestrogenism can promote adenomyosis, and there could be inflammatory reaction, neuroangiogenesis, altered sex steroid receptors, progesterone resistance, proliferation, fibrosis. There are changes in the myometrium as well as the endometrium, and all these together lead to pain, AUB, and infertility. So it's very important to know that it is hyperestrogenism And the various immunological factors and molecular changes are the reason for these severe symptoms of adenomyosis. And when you start treating these women, it's very important to try and reverse these factors. And there are also tremendous changes in the muscular layer, from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis. And this can change the plasticity and tonus of the uterus, leading to menorrhagia, dysmenorrhea, as well as reproductive dysfunction. And I firmly believe that whenever you do a 2D ultrasound, you should also do a 3D ultrasound. Ever since we got our E8 machine in 2013, we have enjoyed diagnosing this more often. You can see here the early infiltration of junctional zone by adenomyosis, and this is focal adenomyosis. It's very important for us, the infertility specialist, to look for these changes so that you can diagnose it at an early stage and start managing them very early. And we know that it is a lifelong management. And management depends on woman's age, clinical symptoms, focal or diffuse, and the reproductive status. Is she interested in fertility or not? Even if she's not interested in fertility, today young women would like to conserve the uterus as much as possible and save the uterus, as all of us have said today, is the mission of the gynecologists today. So we have the availability of medical, surgical, and ART side by side. You can do it alone or in combination, but we do not have very definite guidelines how to treat and when to treat. But lots of data are pouring out over last 2 decades. From the 1993, it is that girl is now 27 years. Tremendous changes have happened in the management of adenomyosis. So about 3 to 4 decades back, what we could offer them was only hysterectomy. And it's around 1952 that the early reports of wedge resection started coming out. But later we started having very many medications for medical management. And you can see here the NSAID, OCP, danazol, GnRH analog, Dynogist, aromatase inhibitors, intrauterine system with the progestrogens, etc. So many medications are available today. NSAID are helpful only for controlling the pain. It does not do anything to heal or regress the adenomyosis. Whereas the first line of therapy for women with dysmenorrhea in many of the European countries today, the therapy for women with dysmenorrhea and AUB is combined oral contraceptive pill. So they cause anovulation, amenorrhea, reduce proliferation, reduce the estrogen levels, reduce the prostaglandin, COX-2 levels, inflammation. But you need to give them continuously. Giving them cyclically does not help at all. However, it is inferior to LNG-IUSS system for control of pain and bleeding. But today, most of us are shifting to progestins rather than COC. As per the papers by Chaperon and Versilini, the past use of COC was associated with higher incidence of endometriosis, especially deep infiltrative endometriosis. So just like endometriosis, even in case of adenomyosis, the shift is more and more towards using progestins. And why do we use progestins? They cause reduction in serum estrogen levels, cause decidualization, atrophy of endometrial tissue, inhibition of matrix metalloproteinases, anti-angiogenic effect, anti-inflammatory effect, immunomodulatory effect, and all these help us for regression of adenomyosis and healing of the lesion. And Dynogist, I would say, is the wonder drug of the decade. It is a 19-nor testosterone derivative. It is a fourth generation progestogen, and it has got central and local effects. The central effect causes inhibition of gonadotropin secretion, causes moderate suppression of estradiol levels, causes anovulation, and locally it has anti-proliferative, anti-inflammatory, anti-angiogenic effect. And it is very effective and well tolerated for the treatment of painful symptoms associated with adenomyosis, mind it, not complicated by severe uterine enlargement or severe anemia. So if there is heavy bleeding and anemia, one should not be using Dynogist. And when you compare it to GnRH analogs, both were highly effective in the treatment of dysmenorrhea, dyspareunia, and chronic pelvic pain associated with adenomyosis, although triptorelin acetate or GnRH analog appear superior to Dynogest in controlling menorrhagia and for reduction of uterine volume. And 26% of women in Dynogest group had persistent heavy bleeding. So this is where the GnRH analogs definitely score over Dynogest. Control of pain is faster with GnRH analog, and control of bleeding is much better with GnRH analogs. But the Dynogest does not cause profound hypoestrogenism like GnRH analog. You can see here that it maintains the estradiol levels between 30 to 60 picogram per ml. So it suppresses the endometrial or adenomyotic lesion growth, but does not cause significant bone mineral density loss. So this is very, very important property of Dynogest, which allows us to use it for, today I think there are papers which say that you can use it for 5 to 6 years. And the side effects are minimal and the patients are most often comfortable, except for some women having the problems of bleeding. But today in the gynec clinics, when a woman comes to me with menorrhagia, dysmenorrhea, what comes to my mind is only LNG-IUS. It has really been my friend for the last 15 years in treating these women. So continuous exposure of LNG leads to atrophy of endometrium. 60% of women can have amenorrhea in 6 months. And continuation rate is around 68%. It gives very good relief from dysmenorrhea and menorrhagia associated with adenomyosis, though you do have some problems of spotting on and off. But some of them go beautifully into amenorrhea and they seem to enjoy it. I know sometimes these girls really become my friends. They come back and say, "Doctor, I'm your happy patient. I have the Mirena for the last 5 years and I'm enjoying the pain-free period." And LNG IUD also act locally and cause deserialization of endometrium and adenomyotic deposits, reduce the local prostaglandin production. You can use it with GnRH analog. It has got better effect than adenomyosis. It has got better effect on adenomyosis than COC, better quality of life than hysterectomy. Most optimal to use it in women with moderate uterine enlargement. However, 69% of 48 patients in the group of Park et al., they had very good relief from menorrhagia and dysmenorrhea. 69% is a very good success rate in women with severe enlargement of uterus. And it can also give rise to volume reduction by 10 to 23% by 1 year. And what I do is I always give an initial GnRH therapy in case of big uteri, wait for about 8 weeks and then insert the LNG-IUS. So the expulsion rate is definitely much less and the continuation rate is much better if you give a GnRH initially and then introduce the LNG-IUS. Occasional side effects are weight gain, irregular spotting, breast tenderness, headache, etc. And we have an ongoing study of my patients with AUB. So you can see that almost 53% of the patients are adenomyosis and endometriosis. And I would say that about 70% of them have retained the Mirena for more than 5 years. And one of my patients, at the end of 6 years, she did not want to remove the Mirena. She just did not come back for follow-up. And she came back after 14 years, saying that I have enjoyed 14 years of bliss. And now she wanted the Mirena removal. So we presented in the UFOXY a story of Mirena of 14 years. Injectable progestins can also be used. They're cost effective, but breakthrough bleeding can be a problem. Dydrogesterone has been advocated for use in endometriosis and adenomyosis because it has immunomodulatory effect, increases the nitric oxide production, and it is said to be not preventing ovulation. But I have not used it much in adenomyosis. Danazol is coming back in the European countries in the form of either vaginal danazol or intrauterine device. You can keep the intrauterine device for about 6 months. seems to reduce the dysmenorrhea, dyspareunia, and pelvic pain. And androgenic effects are very minimal when you use it locally, as per the papers by Tosti et al. And Igarashi et al. But today in the fertility clinic, my friend is GnRH analog. The GnRH analog suppress the gonadotropin secretion, suppress the ovarian function, but they cause profound hypoestrogenism. It reduces the expression of aromatase cytochrome P450 in the utopic endometrium of women with adenomyosis and endometriosis, decreases the expression of nitric oxide synthetase. So it reduces the inflammation, vascular endothelial growth factor, and promotes apoptosis. There is decrease in the size of adenomyosis, and there is a very good volume reduction. But you definitely need to give progesterone add-back therapy to prevent bone loss in these women. Wonderful paper by Neo et al., where he says that a long course of down regulation significantly improved the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate. I'm not going to speak much upon this because Jyoti is going to talk about it. And after 2 to 6 months of GnRH analog, the mean uterine volume significantly reduced from 180 ml to 86 ml. This is what I would like to stress upon. The volume reduction that you can get with GnRH agonist is really remarkable. Nothing else can match this kind of volume reduction. You can also use it post-operatively after adenomyomectomy to prevent recurrence and for getting better pregnancy rates. The rate of euploid miscarriage can be reduced by using GnRH analogs prior to embryo transfer, and it also seems to improve the post-implantation pregnancy health. So abortions can be minimized by using GnRH analog pre-IVF. This is one of our patients who had recurrent implantation failure elsewhere. When she came to us, we diagnosed that she was a case of adenomyosis. This was in 2013 with our E8 machine. We gave her a long GnRH depot, 11.25. After 6 weeks, the regression was minimal, but after 12 weeks, the regression was almost complete and the endometrium is expanding. And 4 weeks after this, at 16 weeks, we did the embryo transfer and she had full-term birth. I mean, she delivered twins at 35 weeks. And this lady with previous 2 IVF failures and previous laparoscopy came to us with severe dysmenorrhea, still wanting a baby, and she had posterior wall adenomyosis, deep infiltrative endometriosis, and also small chocolate cysts. Very tempting to do a surgery, but we went in for a 11.25 GnRH depot. The size of the lesion reduced, and then we did a collection. And in fact, this lady conceived with a fresh transfer. But today there are a lot of papers which favor doing the collection initially, freeze the embryos, then you give the suppression, and later you do the embryo transfer. So frozen embryo transfer is gaining more popularity in the scenario of adenomyosis. This is once again a paper by Matsushima et al. You can see the uterine volume reduced from 307 ml to 177 ml after 16 weeks of GnRH analog, whereas in the low-dose estrogen progesterone and Diagnostic group, there was no change in the uterine volume. And this is a paper in 2018. But to cut the cost and reduce the loss of BMD, you can perhaps give GnRH analog initially, and later you can continue the treatment with Diagnostic in our women who have AUB and dysmenorrhea, because we're all worried about giving long-term GnRH analog. So give an initial bolus of GnRH analog, and after 8 to 12 weeks, you can continue with Diagnostic for a couple of years, the way the woman needs. And our new friends are aromatase inhibitors. These are the second line medication for endometriosis and also for adenomyosis. It can cause hypoestrogenism. So you have to use it along with progesterone or norethistone acetate. One is to prevent cyst formation. Number 2 is to prevent loss of bone mineral density. You can use aromatase inhibitors along with OCP, GnRH analogs, and progestogens. You can use it letrozole 2.5 milligram per day. And there was good reduction of the symptoms of pain and bleeding, and also reduction of uterine volume. And when a combination of GnRH analog and aromatase inhibitors, a reduction in uterine volume was 60%, which is very, very impressive. And one of my patients recently, I could not get this case ready. Her uterine volume was 370 ml initially. And after 10 months of suppression with various combinations of GnRH analog and letrozole along with the add-back regime, her uterine volume came down to 170 ml, and now she is 14 weeks pregnant. I have another couple of cases, and this year I think we are going to take a study of our usage of aromatase inhibitors along with GnRH analogs. You can also use anastrozole 1 milligram along with progestins and can be given for 6 months. They can also reduce the, this is an interesting paper by Abu Bakr and Badawi et al. There was a good reduction in the uterine volume. The green is for GnRH analog. The pink is for GnRH analog. The green is for letrozole group. But when it comes to the adenomyoma volume reduction, both are almost equal at the end of 12 weeks. Unfortunately, this paper came up in 2013, and I think that time, 2012, and that time the letrozole was withdrawn. So perhaps the studies got discontinued, and now that aromatase inhibitors are back, I think it's worth trying them once again because cost could be much less compared to the cost of GnRH analog. But here you can see the same paper, you can see the comparison, letrozole and GnRH analog. Nothing can match the efficacy of GnRH analog. Chronic pelvic pain, the relief is good with letrozole and GnRH, but dysmenorrhea, 57% relief in letrozole group, 100% relief with GnRH analog. Menorrhagia, metrorrhagia, dyspareunia, everything, there is success with aromatase, but it seems to be a poor cousin. Menorrhagia, 60% had success, whereas 100% relief in case of GnRH analog. So GnRH analogs are definitely the most superior of the modalities available for managing adenomyosis, but aromatase inhibitors seem to be good enough. The newer oral antagonist is elagolix. It is an FDA-approved drug. You can use it at the dosage of 150 milligram or 200 milligram twice daily, can be used up to 24 months. But you can also have hypoestrogenism in higher dose and longer duration of treatment. I cannot speak more because we have no experience of using this medication. And you can also use the selective progesterone receptor modulators. Esopressnil can be used. Reduces dysmenorrhea even in minimal doses, inhibits endometrial proliferation, requires more RCT before we talk about this, and I have not used it. You can also use mifepristone and onopristone, which can cause reduction of dysmenorrhea and menorrhagia. And some of the non-surgical interventions like uterine artery embolization and HIFO also have been used for managing adenomyosis. Uterine artery embolization can avoid a major surgery. You can use it perhaps for women who are parous. But for infertile women, still much more RCTs are required because there is always a suspicion about low pregnancy rate, high miscarriage rate, IUGR, and preterm delivery after uterine artery embolization. HIFO, once again, we need more experience in women who need fertility. And this is a wonderful paper by Duhome et al. They are doing exactly what we are doing in Rao Hospital. In patients who desire fertility, you classify them into mild, moderate, and severe. Mild patients, you can treat with ART for 2 to 3 cycles. If there is no relief, then you can give them a GnRH suppression for 2 to 3 months and transfer the cryopreserved embryos. If there is no success, do not rush for surgery. Once again, you can give GnRH suppression and then do the embryo transfer, and most often you will succeed. If it is moderate or severe disease, you do the oocyte retrieval, cryopreservation, once again followed by GnRH analog suppression and transfer of embryos. You may consider surgery if everything else fails. And we always have experts like Dr. Hafiz Rahman who can give good results. And once again, in women with AUB or dysmenorrhea, first line of treatment options are LNG-IUS, Dynogest, or COC. That is in case of moderate enlargement, like 100 to 150 ml. If the enlargement is more than, it's said to be severe, then once again you can use GnRH analog you can use it for, you can use a GnRH analog for 3 months followed by LNG-IUS, or you can use LNG-IUS directly. And my patients are pretty happy for even 5 to 10 years. Some of them have removed the Mirena and got the Mirena inserted again. And if it is not fruitful, sometimes you can consider surgery. You can even consider perhaps hysteroscopic ablation or HIFU, uterine artery embolization, or hysterectomy as the last resort in women who have completed their family. And this is a collection of 56 patients at Rao Hospital, managed medically for infertility, and we had a 63% live birth rate and a 44% pregnancy rate. So to conclude, we have to treat these women medically, whether it is infertility or AUB. And I believe that about 80% of the patients can be managed beautifully medically without going in for surgery. Thank you all for a patient hearing.
Thanks, Dr. Rasha Rao. That was an excellent and exhaustive deliberation on management of adenomyosis. Nowadays, we are looking for subcellular causes and etiology of adenomyosis so that we can do our management accurately and very targeted. There is a shift towards progestins for the management, starting from COC to progestins, and then, as you say, GnRH agonists are your friend. Then we are also looking for aromatase inhibitor, which is your success story, as you nicely told. You have really guided all the delegates, all the attendees, how to do successful management of adenomyosis and not rush for surgery at the first go. Medical management has its place and will remain the place. It was an excellent deliberation, Dr. Asha, and I'm sure everybody has benefited with crisp, key take-home messages.
Thank
Over
you,
to Dr. Jyoti.
Yeah, thank you so much, Dr. Asha. It was amazing presentation. And the experience that you hold speaks for itself. I mean, you have over years so many cases that you have worked in adenomyosis. You have an amazing list of patients. Satisfied patients is very, very important there. Over to Dr. Richa now.
It was really a mesmerizing talk, Dr. Asha ma'am. It was really good. And now we finish this session, and now we move on to the next talk, which is by our charming lady itself, Dr. Jyoti Malik, and she'll be speaking on infertility and adenomyosis. So can you put up the CV, please? So I will invite first chairperson, Dr. Kanti Bansal. Okay, Dr. Kanti Bansal, she is the director of Safal Fertility Foundation at Ahmedabad, Gujarat, and she is a pioneering IVF specialist and many first in her name. She was awarded with FRCOG Distinguished Service Medal. She is the founder, chairperson of Endometriosis Committee, FOXY, and she was the president of ISAR Gujarat chapter 2017 and 19, and she has published 14 books and many papers in national and international journal. So I invite Dr. Kanti Bansal ma'am. Welcome ma'am. And next chairperson is Dr. K.D. Nair. Sir is the senior consultant and head of the department at Akansha IVF Center and Mata Chanan Devi Hospital, Delhi. And he is the president-elect of IFS 2020 and 2021. And sir is also awarded with a Star Ashram 2020 award. And he has several presentations in ASRM and ASHRAE meetings. Welcome, Dr. K.D. Nair, sir. And now I request your persons to introduce Jyoti Malik.
Thank you, Dr. Richa. And I'm really privileged today to introduce none other than the most beautiful, brainy, bold, and all the adjectives that are there. I can really shower on Jyoti. because she's such a darling to most of us. I think all of us. She's so soft-spoken, such a good human being. And you can understand that how she's invited all of us. She's meticulously picked up each and every, faculty. And I'm very happy chairpersons also. And so she's the director of Roots IVF and Fertility Institute, JJIMS Medical Superintendent, JJ Institute of Medical Sciences.
Thank you so much, Dr. Kanti. It is a privilege to have you here. I mean, a person who has worked so much on endometriosis and its allied adenomyosis and chair. I mean, it's my proud privilege to have you here. I think we've already seen this CV before that has been put. So,
that shows how good you are, and so nice. And let's not have any delay. Let's hear another brilliant talk from Jyoti. Yes, come on, Jyoti.
Thank you so much. So I'll share my screen. Thank you, Dr. Kanti Bansal ma'am and Dr. K.D. Nair sir. I mean, speaking in front of the stalwarts and on sharing a dais with such worthy people. I mean, I feel really humbled and really feel privileged. And being the middle order batsman, I mean, I feel all the more happy because if you have a strong batting team ahead of us, you don't need to work so much hard. So in fact, Dr. Ashok Khurana sir and Dr. Asha Rao ma'am, they've already set the stage for me, and I really don't need much to go through on the diagnostic part and on the medical part. And so half of my job is done. So that was very smart of me to come behind them so that I can get their shadows in front of me. So thank you. Here we have the outline where we would be talking on hypothesis, the diagnostic techniques, the mechanism of infertility in women with adenomyosis, the clinical correlations between adenomyosis and infertility, and the various treatment strategies and the reproductive outcomes, and the ART outcomes in these women. So we all understand that adenomyosis is the benign disorder which is characterized by the presence of heterogeneous endometrial gland, heterotopic endometrial glands, and stroma in the myometrium, and reactive fibrosis of the surrounding smooth muscle cells. Now, we all understood the symptoms, the menorrhagia, which is the most common symptom, and dysmenorrhea and metrorrhagia in as many as 1/3, that is nearly 30% and 20%. And in some, dyspareunia could also be a complaint. Now, in as many as 1/3, it is asymptomatic. We just do an ultrasound routine scan and we see a bulky uterus that we used to see in the previous times, which now with the high-end machines that we can label as adenomyosis, as Dr. Khurana sir rightly pointed out. And it basically, actually, it used to affect multiparous women more. And in fact, 20% of the cases of adenomyosis involve younger women, younger than 40, and as many as 80% are women 40 to 50 years of age. So now, because the women are postponing, that is why we are getting adenomyosis more and more in the younger women who have yet to start their family. So previously, adenomyosis was associated with multiparity and not impaired fertility. And currently, though, adenomyosis is diagnosed with increasing frequency in the infertile women since they are delaying their pregnancies. So we have various theories here, how it originates by the invagination of the basalis of endometrium. Then the second theory says that this invagination, along with that, it proceeds along the intramyometrial lymphatic systems. And the third theory says that this metaplastic process can occur de novo. So who are the women at risk? Multiparous, those who had recurrent spontaneous and induced abortions, those who have endometrial hyperplasia. Endometriosis is seen, adenomyosis is seen associated with endometriosis in as many as 20%. Smoking, surgical trauma by cesarean or a curettage, and women who have been taking tamoxifen for a long time, implying that this condition is estrogen dependent. Now, very rightly, Dr. Ashok sir showed us that right from initially we used to diagnose it by pathology. So it was after a surgical resection only and doing a pathology could we diagnose the adenomyosis in the past. But now with the ultrasound machines, with the high-end machines, and with the MRIs, the things are becoming much, much clearer. But still, the transabdominal ultrasound cannot reliably diagnose adenomyosis or differentiate it from a leiomyoma. The only thing that we can grossly see there is that there is a uterine enlargement without any features of fibroids and asymmetric thickening of the interior and posterior myometrial walls, and we start doubting that it could be adenomyosis and not fibroids. But we have the TVS, which is the primary diagnostic tool here. And sir has very, very clearly shown us how do we diagnose it. And if we have 3 or more of the following features, we are sure that we are dealing with a case of adenomyosis. Now, 3D TVS is like a third eye. 3D is the third dimension that we have always to take care of in our cases, wherever any gynec case or infertility case, we have to, it gives us a greater aid, and we see the junctional zone. And when we see that it is greater than 7 mm or maybe 8 mm, there is a myometrial asymmetry or there are hypoechoic striations, our diagnosis becomes much, much closer to adenomyosis. And at least 2 of these 3 features, if they are present, we are at least 90% accurate. So this we have gone through very thoroughly, how we diagnose it on an MRI, and in an MRI, it is strongly considered that when the junctional zone thickness is greater than 12 mm, we are dealing with adenomyosis, and it is a very good negative predictor of implantation failure. And there is an increase in the JZ diameter is inversely correlated to the implantation rate. So we may not need MRI every time if we have a 3D ultrasound, but sometimes if we are doing a MRI and if we see that the junctional zone is increased, then definitely we start becoming, our counseling becomes more easier. That means the implantation may be lower in these cases. So what are the mechanisms, how it causes infertility? So it affects at many very places. It affects the uterotubal transport. Adenomyomas distort the uterine cavity, and they may obstruct the tubal ostia and interfere with sperm migration and embryo transport. Now, there could be the destruction of the normal myometrial architecture and the function. So ultrastructural changes, they cause the disturbance in the normal calcium cycling in the affected myocytes, with subsequent loss of the normal rhythmic contractions and affecting the uterotubal transport. Also, the peristaltic activity normally originates solely from the junctional zone, and the outer myometrium remains inactive. But in hyperplastic muscular tissues, there is hyperperistalsis, which increases the intrauterine pressure and affects the uterotubal transport. Now, increased activity in this zone, in this junctional zone, just before embryo transfer in IVF is also associated with a reduced pregnancy rate and an increased frequency of ectopic pregnancies. Now, adenomyosis affects the endometrial function and receptivity. And cytochrome P450 expression is increased in these women. And these women, this expression can tell us that these women are at an increased risk of IVF failure. And a treatment with GnRH analogs decreases this expression and therefore makes these women more and gives us better chances in IVF-ICSI in these infertile cases. Abnormal inflammatory response is there in these women with adenomyosis. Normally, the stromal macrophages, they produce pro-inflammatory cytokines. They produce TNF alpha and interleukin 1s. But ROS also is produced in these cases, which is very toxic to the embryos and hence causes recurrent implantation failures or recurrent IVF failures. There is also altered expression of the estrogen and progesterone receptors in these women. And there is a reduction in the expression of the progesterone receptors, causing upregulation of the estrogen receptor alpha. And because of this overexpression or the upregulation of the estrogen receptor alpha, there is a reduction of the beta 3 integrins, which alter the uterine receptivity. So also they impair the implantation. How it happens, there is altered oxidative stress in the uterus. There are excessive free radicals which interfere with the embryo development. There is impaired implantation because of lack of expression of the adhesion molecules. There is reduced expression of the implantation markers. And LIF, that is the leukemia inhibitory factor, is a very essential cytokine, which is indeed very important for a successful egg implantation. And adenomyotic endometrium shows abnormalities in the production of LIF, which contributes to altering of the uterine receptivity. Then also there's an altered function of the genes for embryonic development, and a HOXA10 gene, which is essential for the embryonic development, is lower in the stroma of these women, thereby causing the impairment of implantation. So it affects at so many various levels. It affects the endometrium, it affects the uterotubal transport, and it impairs the implantation. So that is how it is affecting the fertility potential of these of the women. Now, this is something which we have all gone through. Dr. Asha Rao ma'am has absolutely made us very crystal clear what medical treatment, how much dose, when, and what is the best. Denogest definitely is the gold standard coming in our cases of both endometriosis and adenomyosis, because it is very, very effective in dysmenorrhea, dyspareunia, and the chronic pelvic pain. LNG IUDs are very, very effective. But for infertility, we have only one friend here, and that is GnRH analogs, because they cause down regulation of the gonadotropin releasing hormones. But obviously, there is another side to it, and because of the risk of osteoporosis, we cannot give it for long, and it needs to be given only for a short duration of 3 to 6 months. But we can increase the duration if we give the add back estrogen therapy in these cases. So medical treatment, not for our infertile cases. These are all basically for menorrhagia, dysmenorrheas, pelvic pains. But for infertility, the only thing that we have is in our basket is the GnRH analogs. Now, what are the different treatment strategies and what are the different treatment outcomes? Should we be treating adenomyosis? Does the treatment help? Does medical treatment help, or does the surgical treatment help, or is it the combined treatment? What is what? So these are various studies that have come up, and we can just go through them so that we understand that how much treatment in what case and which ones. So when there are various many studies here, and seeing that when we gave GnRH agonist in these women. So this was the study by Wang et al, where they studied 37 cases over 6 months, and these women had a duration of infertility more than 3 years, and within a year, these women had a very good 3-year pregnancy, cumulative 3-year pregnancy rate of 10.8%. Now, this study where they had 22 women, and they also within a year to 1.5 years, they had a very good pregnancy rates. So GnRH agonists are really magical in women with adenomyosis and who are subfertile. Now, should surgery be done in them? So we do not know who will benefit from medical treatment alone, just like ART, and who will benefit from the conservative surgery. We also don't know what is the appropriate time when we should refer these women of adenomyosis to a ART specialist or to a surgeon, and we do not know which thing will, whether there'll be an improvement in the reproductive performances. So when there was a conservative surgery, so there are various many papers here, and we can go on to this Wang et al. They had done quite a good number of 51 conservative surgeries, and they got a clinical pregnancy rate of 74% after the conservative surgeries. And what are those conservative surgeries that we would come in our next talk, which Dr. Hafiz Rehman sir is going to give his insights onto those conservative surgeries in adenomyosis. So now we had, then this was a Osada and Kishi. They have done a lot of work on this subject. And they did, in Osada's series of 26 cases, there was spontaneous clinical pregnancy in 4. And in Kishi, in 102 cases, this was a very, very important study. And I would like you to see here that the clinical pregnancy rate was 41% in women who were less than 39, who were 39 or younger, and 3.7% in women aged 40 years or older. So this is something that we should all make it very clear, that if we are subjecting our woman to conservative surgery treatment, we have to focus on her age. And if the age is 39 or less, then only she should be subjected to surgery, because then only her pregnancy rate is going to be 41%. Now this was another this is the same actually study here, where they have worked on these women who were younger, and they have stressed that there is no clear benefit of surgery on fertility outcome on women who are more than 40 years. And a lab cytoreductive surgery might be suitable for women with localized adenomyosis who have failed the usual infertility treatments and ARTs. Now, this was this combination of microsurgical cytoreduction and GnRH analogs could be appropriate for the patients who have failed only GnRH analogs or who could not tolerate them for a longer time. So these are various mixed reports actually. So, I mean, still we are not very clear. And here we see that the ART outcomes and ongoing pregnancies in these women with adenomyosis, here we, in this Salim and Thaluri and the Mobun, these people, they have seen that the adenomyosis, definitely the pregnancy rates are much lesser than the controls, whereas other people like Xiang, the Costello, and this Martinez group, they did not find any much difference between the adenomyosis and the controls in the women who were going ART and the pregnancy rates in them. So still we still have a long way to go and decide what we need to do, which treatment to do. Though we should definitely have in which cases should we go for surgery? For those who desire for pregnancy, those who have recurrent IVF failures, and those who are less than 39 years of age. And does it affect fertility? Yes, definitely. In this, we have seen that it is affecting the clinical pregnancy rate. So there was this by Tulendi, this was a meta-analysis, and in the fertility sterility in 2017, which says that the rate of implantation, the clinical pregnancy rates, and the live birth rates was significantly lower than those who had those without adenomyosis, and the miscarriage rate was much higher. And it appears that the surgical treatment or a treatment with analogs increases the spontaneous pregnancy rates in women with adenomyosis. So algorithm that Dr. Asha Rao ma'am had also shown, and similar algorithms which says that routinely you do infertility workup, see her ovarian functions, do the semen analysis, and if they have these women with adenomyosis associated infertility, do a long protocol GnRH agonist suppression for natural conception, the women who have the normal ovarian function, but you have to go in for an urgent IVF in women with a diminished ovarian reserve. So we cannot, if the ORT is diminished, then we don't have a time to lose or any trials, and straight away we have to refer them for a IVF. Now repeat the long protocol, GnRH agonist based IVF ICSI treatment if the natural conception is not possible. And still if we have failed, then one can go in for a type 1 or type 2 conservative surgery, and then urgent long protocol IVF ICSI 3 months after the complete treatment. Now, this is the same thing. If we have a ORT which is normal, that is the ovarian reserve test, which are normal, we follow a long agonist protocol and natural conception. But they are, if abnormal, going for IVF. If if it is a failed natural conception or a failed IVF, repeat IVF. But if it is a failed IVF repeatedly, then we have to have a conservative surgery followed by a IVF after 3 months. So this is something, the type of surgeries that we will come up in the next talk by Sir. And the type 1 is the focal type, where we do a complete excision, which is an easy technique and the risk of rupture is low. Whereas in type 2, it is a diffuse type, a cytoreductive surgery, difficult surgery. Not everybody should try it up. Only the people who are really expert in it should be venturing onto it. And because the risk of rupture uterus after pregnancy in these women is very, very high. Now, in a localized adenomyosis, we can have very good pregnancy rates as high as 50 to 75%. And although the conservative surgery might not have a similarly promising effect on reproductive performance with diffuse adenomyosis, still the hope is not low to have good pregnancy rates. Now, what are the risks of conservative surgery? It leads to adhesion formation. It can deform the uterus, cause occlusion of the tubes. We might land up doing a hysterectomy, similar to what any kind of uterine surgery, including a myomectomy, that we have to counsel the patient before doing a surgery. And very, very important that uterine ruptures might occur during pregnancy or labor after conservative surgery for adenomyosis. So we have to be very careful. Now, this is which GnRH analogs have to be given. This is very important, very good paper and very good study that they showed that pre-treatment with a GnRH analog before IVF treatment improved the pregnancy outcome. And this study, they analyzed that the efficacy of leuprolin acetate in the treatment of adenomyosis with infertility after 2 to 6 months of this therapy, the volume was really reduced to 1/3. From 180, the volume was 86, and there was a good improvement in the embryo implantation and the clinical pregnancy rate. So it is very, very the magical results that we can expect in these cases. The stimulation protocol, very clear, there are no doubts. We all have to follow the GnRH agonist long protocol cycle rather than the antagonist protocol, because everywhere we are just following the antagonist protocol, which is giving everybody very good results, but not in adenomyosis and endometriosis. So this is something one has to keep in mind. And the two-stage IVF that Dr. Asha Rao was telling about. So here what we do is we do the ovarian stimulation, we do the retrieval, do the fertilization, prepare our embryos, and do the frozen embryo transfers at a later stage. So in between, after we have done those pickup and frozen, we can give these 2 to 3 cycles of agonist depots every month. And after that, maybe once the uterus has shrunken, the endometrium has become receptive, we get a very good results after for frozen embryo transfers in these cases. Now, frozen embryo transfer in the first HRT cycle following the analog suppression should be given before the adenomyosis lesion regrows to its pre-treatment size and exerts its adverse effect. Now, mock embryo transfer is very important in these cases because the uteri in these women are big, they have enlarged uterus, the cavity is distorted, and the mock transfer helps us assess the cavity length and the position of the uterus and helps us to choose the correct transfer catheter and mentally prepares us whether it is going to be an easy transfer, whether we need to use a tenaculum or a dilatation to to hold the uterus or to intubate the uterus. So mock embryo transfer is important in these women. Very, very important. We should all just remember this, that single embryo transfer should be done in these women because anyhow these women are at increased risk of preterm deliveries, preeclampsias, and second trimester miscarriages, and therefore multiple pregnancies should be avoided, and only single embryo transfer should be advised. Also, there is a risk of scar rupture, as I had stressed initially, and therefore also a single embryo, singleton pregnancy should be the rule, and multiple pregnancy should be avoided. So these were the various references that I had taken, and thank you so much for the patient listening and for joining. It was wonderful. Thank you for giving me this opportunity to do this small little bit on my.
Come behind me if you want to.
Very much, Dr. Jyoti. Excellent deliberation by you. You spoke right from the basics, how really adenomyosis causes infertility. And then you went on with, some of the things that Dr. Asha had so beautifully told in her lecture. And then you went on to say how GnRH agonists really do help these patients of adenomyosis with infertility. And then the last but not the least, how important it is to do a mock trial before we do the embryo transfer. And I really admire for your beauty and brains. And thank you so much for this wonderful talk. And I would now request Dr. Nair to please give us a brief summary of whatever she said. Thank you.
Dr. Jyoti, it was a wonderful talk. I must congratulate you. I must congratulate you on specifying that the surgical treatment of adenomyosis is not the first choice. You have to give the GnRH agonist, and if you fail, the IVF fails once or twice, then you think of doing for surgical treatment. Dr. Hafiz is the next speaker. He might not agree. He will say, okay, let us operate on every patient who comes and then think of GnRH agonist. But as an infertility specialist, we like to give agonist first. And the two-stage treatment which you mentioned, that you do a oocyte retrieval and freeze the embryos. That is what we are doing in our center. But then we give a long-acting agonist. We are giving 11.25 milligram, which lasts for 3 months. After 3 months, we give HRT therapy, HRT cycle, and do the embryo transfer. We have got a small series of 5 patients who are conceived with this two-stage medication retrieval followed by 11.25 milligram leupride, and then do a embryo transfer. I think it was a beautiful discussion. And Dr. Ashara, before you has also spoken about it, I listened to it before also, that the mainstay of treatment for adenomyosis is the medical management. The surgical management come later on. And one has to be very meticulous. A surgeon like Dr. Hafiz Rahman can do a meticulous surgery, but a surgeon like me might not be able to do any justice to the patient. And let us listen to Dr. Hafiz, what he's going to say.
Thank you so much, sir. Over to Dr. Shashi. Dr. Shashi Kabra. Thank you, sir.
I think there are a few questions that Asha has. So, Richa, if you could ask those questions before we move on to the next lecture.
Ma'am, can we put the answers in the chat box because we are already, it's 6 o'clock and maybe, or we can take it a little later if you allow.
Yeah, sure.
I think Dr. Shashi.
Dr. Hafiz will stop now.
Yes. Dr. Shashi, are you there?
Hello?
So, yes, yes.
Hello, Dr. Jyoti.
Yes, yes, yes. So now please introduce our next chairpersons, Dr. Shashi.
Hello.
I think Dr. Shashi's signals are a little poor, I suppose. So I would do the needful on her part. Dr. Shashi. So we have our last but not the least, the talk, which is very, very important. Everybody is holding to that last bit of it. And it is the two beautiful chairpersons that I have. I have the privilege of introducing. We have already had Dr. Richa Sharma here. I've already introduced her. She is the AOGD committee, endoscopy committee chairperson, and she is a professor at UCMS GTB Hospital, Delhi. So she would be chairing this very, very important session. And then we have Dr. Dinesh Kansal. Can I have the CV? Yes, we another very senior who is very close to my heart and a very admirable person, Dr. Dinesh Kansal, who is president of Delhi Gynae Endoscopy Society and IAGE Managing Committee member, convener and examiner for ICOG Fellowship Program, head of department at BL Kapoor, Delhi, and a very keen interest on her robotic surgery. And she is one of the faculty in the IAG for robotic surgery. Welcome the two chairpersons, and over to you.
Thank you, Jyoti, so much for such sweet words. You are such a great friend. And it's my pleasure to introduce Dr. Hafiz Rahman. He's such a renowned surgeon from down south. And I think he's one person whose workshops are, can we have a CV? Yeah, he's the one person whose workshops are, have hugely filled halls. Whenever he has in Delhi, I've seen, and he owns and is the director of Sunrise Group of Hospitals. That's in South, that's in Delhi, then UAE, Africa, and really proud to have him in this webinar today. And he does the surgeries, the same surgeries in a different manner, and we always go to attend his workshops to see something different, something new. So, so we are here to watch you, Dr. Rahman, your conservative surgeries basically. Otherwise, hysterectomy, I think nobody would be interested in seeing. So let's see what you have in your basket. Welcome, please, and you can share your screen. Dr. Hafiz,
yes, I'm there. 1 minute.
Please.
Can you see my screen?
Yes, very well.
Can you hear me well?
Yeah.
Yeah. Just hold on a moment. Now, I think all of you must be quite confused enough with this enigma of adenomyosis. And I'm happy that Jyoti has given a very good balanced view on how to treat adenomyosis, even though that we do not know anything much about adenomyosis. You know, when Dr. Asha Rao was speaking, she could give a big list of medicines which can be used for adenomyosis. Whenever a list of medicines is larger for any disease, you know very clearly that you don't actually have any treatment. And when now I am talking, I'll give you a good list of surgeries, good number of surgeries which can be done for adenomyosis, that also shows that we actually do not have much treatment surgically also, other than doing a hysterectomy in adenomyosis. As you know, when you have a headache, the best treatment you can do is the 100% cure is the chopping of the head. Like that in adenomyosis, you remove the uterus, definitely you will have a cure only for the adenomyosis, may not be for the infiltrating endometriosis, which is the same actually. But there are certain things you need to understand regarding adenomyosis, which is completely different from endometriosis. I would say that it's a totally different disease as such, because there's nothing much similarity between the endometriosis of the ovary and tube, which produces endometrioma. And here the facts are the effects of adenomyosis as far as infertility is concerned, with Jyoti Malik has put very clearly that it is because of the ectopic endometrium. It's a different endometrium, and the junctional zone adenomyosis and the inflammatory derangement because of adenomyosis. So adenomyosis per se, we are very sure that it doesn't respond to medical treatment. Adenomyosis, make it very clear, it does not respond to medical treatment. Why I say it does not respond to medical treatment is because it does not get cured. How much ever medical treatment you give for adenomyosis, the moment you stop the medical treatment, it's back again in the same vigor. But infertility with adenomyosis does respond to medical treatment. Yes. So it's basically the symptom which is responding to medical treatment. Infertility, as well as you take pain, it does respond to medical treatment. So basically adenomyosis, all the medical treatment which we have are symptomatic treatments. See, like fever, you have paracetamol, fever does respond. But the moment you stop paracetamol, if the cause is still there behind, the fever comes back again. So adenomyosis, unlike the endometriosis, where if you give GnRH for endometriosis, endometriosis actually heals, because there is a cycle of producing cyst and then healing, it goes on. So endometriosis heal. Adenomyosis does not heal, which is one of the most important things you need to understand in cases of adenomyosis treatment. So today we will discuss not only on infertility. I know Jyoti has covered fantastically well on infertility. We will discuss on adenomyosis. We will discuss on ACUM, that is accessory cavitary uterine malformation, which is basically something similar to juvenile cystic adenomyosis. We will discuss on endometriotic fistulas, which are also part of adenomyosis. And we will discuss on cervical adenomyosis, which is a little different topic, and different types of surgery also we will discuss. So one thing basically you have to understand is the cystic adenomyosis is much more responding to medical treatment compared to surgical treatment. So what we do is we prefer to do, if I see a large solid adenomyotic nodule or a large solid posterior adenomyosis, I would prefer to do a surgery first, repair the uterus properly, give GnRH, because anyway after adenomyosis you cannot do an IVF or ask for pregnancy. You need to wait at least 6 months. So during that period you can treat with medically, the inflammation reduces. But if it is a cystic adenomyosis, surgery has less results compared to the solid adenomyosis. So medical treatment would be more ideal before the surgery as such. Now, the basis of surgery is that, see, we are removing the lesion. This removal of the lesion, to some extent, reduces the inflammatory response and the infertility. It will be beneficial. And definitely, there is a reduction of symptoms. And of course, when you remove only the lesion, preservation of the uterus and endometrium is very, very important. This, I would say, you have to read it to really underline this sentence, that preservation of the uterus and endometrium, because it's not just removing the lesion, but more important is what you are leaving behind. It's not what you are removing. You may remove the complete adenomyosis, But more important for infertility is what you are leaving behind. You have to leave a proper uterus behind. You have to leave a vascular endometrium behind, because many cases, if you are not good at your surgery, you will ultimately damage the basal layer of endometrium, which is very, very important, and ultimately end up in severe Asherman or intrauterine adhesions. Now, the different surgeries which we will discuss today regarding adenomyosis, one is the local adenomyomectomy. You have the T-shaped adenomyomectomy. We have something known as a knife adenomyomectomy, the aquam and gross wedging, which is not part of infertility, but it is part of reducing the disease, still preserving the uterus, and it will reduce the recurrence of adenomyosis a lot. Now, coming to the local adenomyomectomy, as you can see here in this case, so this is how we usually do a local adenomyomectomy. When the adenomyosis is localized, you can see that it's in a localized area. This is very good results when you do it surgically, because this is one of the cases where surgery is the most preferred treatment rather than going in for medical treatment. You can see that the endometrium is here. If you see, this is the endometrium coming into the place. So you have to preserve the endometrium. Just go a little above the endometrium and then do this excision here. Now here you can see the T-shaped adenomyomectomy, where see most of the time in a generalized adenomyosis, it is quite difficult if you just wedge into the adenomyosis, because, and not only that it is difficult, you will find that the closure of the wound is much more difficult. So nowadays, this is what we usually do. We do something different from the Osada method. Osada method is a little more radical compared to the other methods. Here we are doing the T-shaped adenomyomectomy. You can see that you can see the flaps are raised. You have a T-shaped incision here if it is anterior, and you can see nicely the flaps are raised, and you can see the adenomyoma here. Can you see that? So this is the adenomyoma. Now here it is very, very important to understand where the endometrium is. For understanding where the endometrium is, you need to actually, usually you can put in a sound and perforate here to understand where the endometrium is. Or else if you are sure on ultrasound, you can chop off this adenomyosis. A thick layer of adenomyosis can be chopped off like this. And usually we use a tenaculum grafter so that the catch is quite good. So you can see that a good chunk of tissue can be removed, and the endometrium, you can see it is down below. You can see the amount of adenomyosis which is removed. See, unless you remove it like that, you will not, just a small piece of adenomyosis removed, it's not going to benefit you at all as a surgical treatment of adenomyosis. You need to do a proper adenomyomectomy as you remove a larger chunk like this, and this can be done posteriorly also, but most important is how to repair it. Because unlike myomectomy, you are here removing part of the myometrium. So it is very, very important to know how to repair this defect. So what we do is we do it as a double flap. We do it as a overlapping flap method. We are using a barb suture, as you can see here. A barb suture is used, and you can see how an overlapping flap comes here. You close one flap initially. You have to be very careful when you take the sutures there. It should not go inside the endometrium. So one flap is closed initially, and then the other flap is usually closed over that flap. As you can see here, can you see that it's just overlapping, so that you actually have a good scar integrity when you do like that. So you can see how it is overlapping, and this wound is also closed with overlapping sutures. Now, this same thing can be also done with a knife, basically, because one of the most important thing which you should understand is to understand the extent of adenomyosis. It's very important, very difficult to understand the extent of adenomyosis if you are using any energy source usually. That's why many times we use scissors, but at times scissors will not be much useful because it is very difficult to get a very sharp scissors. Many times we have to use a disposable scissors. So this is basically a laparoscopic knife, which you can see. When you cut with a knife, the identification between the myometrium and adenomyosis is much more better. As you can see here, see this is the level, this is the myometrium, and here you can see the adenomyosis. Again, you are doing a posterior T-shaped adenomyomectomy. As you can see, you have a horizontal incision here, and you have a vertical incision here. And then you can see how the knife works. The knife can just go inside also, and you can push it inside. You have to be extremely careful that the pneumo doesn't go. Then you raise the flaps here like this. So this is how you raise the flap. You can see that even though you are doing with the knife, see, this is a part of adenomyosis. You can see very clearly the differentiation between the adenomyosis and the normal myometrium. So with a knife, it is much more easier than with the harmonic scalpel or any other energy sources. See, here you can see that you are cutting little into the adenomyosis. So that you can correct it later on. You can see how the knife can go in fast if there is a pneumo leak. You have to keep adequate amount of myometrium in the flap. Can you see that difference? See, this is adenomyosis here. This is adenomyosis, and that is the normal myometrium. You can see the difference very clearly. See that? You have to be careful that you do not buttonhole the flap. And slowly you can take it here. You can cut it deep. And this knife becomes much more useful when it comes to the endometrium. When it comes anteriorly onto the endometrium, it becomes much more useful. Here you are doing it posteriorly. Can go down right up to the cervix and scoop out the large chunk of adenomyosis, as you can see here. You can see how large that adenomyotic nodule is, but you can easily scoop it out as a round nodule with the knife, much easier than many other instruments. And of course, this knife is disposable. It is just like the usual surgical blade. And here you can see the endometrium. Can you see the endometrium? This is the endometrium, quite anterior. And when you see the endometrium, you can actually keep 1 centimeter or half a centimeter away from the endometrium so that you are not going to damage the basal layer much. You can see here, that is the endometrium here. You can see that you are keeping quite away from the endometrium. That is the advantage of knife. And another thing is you can actually feel the adenomyosis with the knife much better than harmonic or any other instrument. So here it is very, very important to save the junctional zone damage or the basal layer endometrial damage, because if you damage the basal layer vascularity, this can go into a lot of Asherman syndrome. Here you can see the endometrial cavity here, as you can see here, and you can see the thickness which is left when we are taking out the adenomyoma. So you need to keep a centimeter away from the endometrial cavity. because it is very, very important to understand this, because this otherwise can lead to permanent infertility because of severe Asherman. Ultimately, you will end up doing an adenomyomectomy and having a permanent infertility if you are not very careful. That is a sound which I have kept to understand the endometrium here. It is very easy also to take out the residual adenomyosis also. You can see here, there is some amount of residual adenomyosis, which we are actually taking out again with the knife, as you can see. That's where you can take out the residual. You can palpate and see and then take out the residual adenomyosis also. So that is the biggest advantage of this endoscopic knife. It's actually very useful instrument since it is disposable. Not the instrument which is disposable, the knife is disposable like it's your normal surgical blade, as you can see. But you have to have a good blade. It doesn't fall inside the peritoneal cavity. As you can see, you can chop off this adenomyosis completely like that. Now, another method, leave alone infertility. We had a lot of patients who have severe adenomyosis. This is also fibroid also, who had severe adenomyosis, who does not want to remove the uterus. Especially in Dubai and all, there are a lot of Arab patients who does not want to remove the uterus. They suffer from all the problems of adenomyosis, bleeding, pain, but they will not allow you to remove the uterus. So that is how we designed this method. This is one method designed in Sunrise, where we wedge the uterus completely. The central portion of the uterus with the anterior and posterior part is wedged. See, the principle behind this type of wedging is two. One is, usually we find that the lateral portion of the uterus, that is the area where the uterine artery is, you do not find much of adenomyosis. Even if you do the histopathology, we have done the histopathology in 10 patients before we designed this. You do not find much of adenomyosis in the lateral portion of the uterus. We do not know why. Usually it is seen in the anterior as well as the posterior portion of the uterus. You can see that. So we are keeping the lateral portion of the uterus. Now the lateral portion of the uterus is kept due to some advantage regarding the ovarian vessels. The uterine vessels which are supplying the ovary will be preserved. So we assume that the chances of ovarian failure will be much lesser, and the patient has a psychological comfort. I think there is nothing more than psychological comfort that uterus is preserved. It is almost like a subtotal hysterectomy, but when you do an ultrasound, you will find that the uterus is still preserved there. See, this is how you remove it. This complete central portion of the uterus is chopped off. Then you have to remove this rectovaginal endometriosis also. So you can see how the uterus is removed there, and then you can reconstruct the uterus. So now you have both lateral parts of the uterus, and then you can see that how the uterus is reconstructed. See that? So the uterus is almost completely reconstructed like that. You bring both the lateral parts in the center and keep it. One thing which you have to be very clear is that you have to take out the corneal endometrium. Otherwise, this can lead to hematometra. So be careful that you take out the corneal endometrium so that no hematometra will. So this is the uterus which is completely reconstructed, as you can see here. And the results are quite good. The patient is happy and the pain is reduced. Menorrhagia will be reduced. And this can be one method of treatment for any benign uterine disease like adenomyosis or fibroid. Any of them, this can be one method of treatment to have completely reduced the bleeding, reduce menorrhagia. There is another method in this where we do a designer uteroplasty, where some patients have an urge to have some menstrual bleeding. Some patients do not want to have any menstrual bleeding. Such patients, we take the endometrium right up to the cervix. Those who need some menstrual bleeding, we'll keep little lower part of the endometrium so that she will reconstruct the uterus on top of it, so that she will get some menstrual bleeding, so that they feel that the femininity is much more preserved. See, it's very important to address the psychological needs of your patients as they are female patients. very important to address the psychological needs. It's not just chopping of the uterus and getting cure of the disease. So this is also extremely important. Now, complications of adenomyomectomy, mostly bleeding, it never occurs. Do not ever think of doing a hysterectomy in an adenomyomectomy patient. You do not have much bleeding in adenomyomectomy because we have done thousands of adenomyomectomies. Unlike myomectomies, bleeding is extremely less, and today in the era of vasopressin, we don't have to do any of uterine artery ligation or anything. Rupture and intrauterine adhesions are the most important complication. So rupture, again, adenomyosis has a much higher chance of rupture compared to myomectomies. It's very important to repair the uterus properly. As I said, what you leave back is much more important than what you take out. The uterus you leave back has to be proper and properly repaired, and prevent intrauterine adhesions by understanding the actual pathology and keeping away from the basal layer of endometrium where the vascularity is there. You damage the basal layer of endometrium, the complete endometrium is damaged. As in a tough or harsh curettage, what happens? Now, to prevent rupture of endometrium, one method which we have seen is that you can do the adenomyomectomy, and as you can see, you can close the uterus. And as you can see here, after closing, you can do something like a mesh plasty. Keeping a mesh, it's a Prolene mesh, it's a titanomized mesh, you will not have any additions. Actually, previously for myomectomies, people used to keep the Gore-Tex mesh to prevent addition. It's a non-absorbable mesh used for myomectomy to prevent additions long back. So either you can use a Gore-Tex mesh or you can use this kind of mesh here also. You can see that here. That is the mesh plasty which is used. The usual question which comes when I talk about this mesh plasty is the expand. So far we have 3 patients who have become pregnant and absolutely no issue for uterus expansion. They will have little pain, but there will not be any issue for the uterus to expand. This what you are using is a physio mesh. As you can see here, so one side it will get adherent and the other side it will not get adherent. So these are actually put with absorbable tags, or you can even suture this mesh. We had one patient actually with pregnancy where adenomyomectomy was done, and she had a very large bulging scar, 1 millimeter thickness, 16 weeks pregnancy with a twin pregnancy. That case also, actually, we did a laparoscopic mesh repair with the pregnancy in situ. She didn't continue the pregnancy. I think around 22 weeks she aborted. But one thing which I have to specify is that she aborted vaginally. She didn't rupture the scar still. Even after aborting, she didn't rupture the scar still. The mesh was in place, and now she's going for the second pregnancy after the repair. So mesh plasty, I can vouch today that it is a very good method. If you feel that the adenomyomectomy scar which you have sutured is not good enough, may not be applicable as such. Now, hysteroscopic resection, I do not prefer hysteroscopic resection for the very fact, that hysteroscopic resection will damage more of the junctional zone. Because junctionoscopic resection of adenomyosis, you cannot preserve the junctional zone or the basal endometrium, and thinning of the myometrium is much more in hysteroscopic resection because you do not have a chance to repair it. When you cut the endometrium, you can overlap and repair it much better. Here you have thinning of myometrium and you are leaving the myometrium just like that, only for the reason that there is no incision. It doesn't work out like that. This myometrium can have problems, and this can rupture even after the surgery. Now, adenomyotic fistulas are very important. As you can see, whenever there is some kind of cryptomenorrhea, adenomyosis occurs in cases of cryptomenorrhea, and this can produce fistulas into different areas. We have seen fistula in cryptomenorrhea because we have a large series of Mullerian anomalies which we have, and in these cases sometimes you have seen fistulas into the urine, into the bladder, as you can see here. Can you see that? So that is a fistula which is occurring into the bladder because of adenomyotic infiltration. The only treatment for this is to repair the cryptomenorrhea. This was due to agenesis of the vagina. We did a vaginoplasty with ileum, so that got repaired as such in this case. And here you can see this is a very interesting case. This is a very interesting case, as you can see here. This was a patient where we are doing a vaginoscopy. She had a didelphys uterus. We could see one cervix, the other cervix was didelphys dicollis. The other cervix we could not see inside the vagina. So we had put in dye into the other uterus, the other side of uterus. We could see dye was coming from somewhere. We could not identify where the dye is coming. Ultimately, we went backwards here. That is this one cervix you can see. Just give me a little something. You could see that the dye is coming from the side, so we went back. You can see vaginal septum. Can you see the dye producing some kind of cryptomenorrhea? So we went into that. I'll show you the septum. See, can you see the dye where it's coming from? That's a vaginal septum. So I'm going into that vaginal septum. When I went into the vaginal septum, I could see 3 holes. There was an adenomyotic cavity which was blind. There was a vesical fistula which was there due to adenomyosis, and there was the other cervix also. So three things were there in this patient. I'll show you that. See, this is the adenomyotic cavity which you can see, which was just a blind cavity. So you need to excise it. And that on top you can see the vesical fistula. That's a vesical fistula on top, which is again due to adenomyosis. These are infiltrating adenomyosis. Sorry. These are basically infiltrating adenomyosis. And I'm going into the cervix. See, can you see that? We are just going into the cervix and we are going into the uterus. You can see the Veris needle which is kept into that uterus. Can you see that? With that Veris needle, we were injecting the dye. And when I come back, that is the unicornate uterus on one side. And when I'm coming back, you can see the, that is a cervical canal. So I'm coming back still more. That's just coming out of the cervical canal. See again. And this patient, see, can you see that? Can you see the other cavity? This is the adenomyotic cavity. Can you see that? And on top, you have the fistula also. So this is the adenomyotic cavity, and top we have the fistula. What I did is we excised that septum and we excised this adenomyotic cavity also. So adenomyotic cavity is also excised and the septum was excised. She got complete cure and she became pregnant. We had done an encerclage for this patient and she has delivered at 38 weeks. Unicornate uterus, first chance itself because we did an encerclage, she went to term with a unicornate uterus. Actually, it's a bicornate, but then in one horn means you have to consider this as a unicornate uterus. Now, cervical adenomyosis is another thing which you have to address. In this case, you can see that when we did hysteroscopy, you can see this was missed in many cases. You can see, can you see that dirty thing coming from the cervix? You can see the dirty fluid coming from the cervix. When you go into that, you can see a proper adenomyotic cavity. The only treatment for this is excision of that cervical adenomyosis completely. Any other treatment short of excision of this cervical adenomyosis will not be fruitful at all. She will keep on having she will keep on having infertility if you do that. And you can see here, you can see the nice cavity inside. See, that's an entire cavity, almost similar to the uterine cavity. This is inside the cervix, quite big. See, it is stained with altered blood. No ostia seen. This is not septum. This is a complete cavity inside the cervix, quite big, and we went ahead to excise it laparoscopically. Now, ACOM is another thing. Do I have time? 5 minutes?
Yes, sir. Please continue.
Okay, I'll just share the, just a moment. Do I share?
But would you include ACOM in adenomyosis?
ACOM is something which is called an accessory. You can see this. Can you see this sharing?
Yeah. No.
See the video. Okay. So this is called as accessory cavitatory uterine malformation. These are.
So we can't see the
it's
video.
not visible, sir.
You can't see the video?
No.
We have to click it again, sir. It came and went out.
Oh.
Because it's classified into congenital anomaly rather.
Yeah.
Yes, now it is shown.
We don't know actually. It could be congenital anomaly or it could be an adenomyosis, but there are two different entities in this. See, one is juvenile cystic adenomyosis, which occurs in the same area. The other one is accessory cavitatory uterine anomaly. See, I am not sure whether it can be classified as a congenital anomaly because in these cases you will find both ostia. If you do a hysteroscopy, you will find both ostia. See, if it was a Robert's uterus, it is completely different. You will find only one ostia and a bulge like this. That is a congenital anomaly, but this one I'm not very sure. You will find a proper cavity in this. In ACOM, you will find a proper cavity. In juvenile cystic adenomyosis, you may not find a proper cavity. You will find a mass or you will find multiple cystic areas. See here, if you can see here, see that I'm just cleaning it. Sorry, it's an unedited video, so. Can you see that? This is the mass which is coming out, and I'll just show you the proper cavity, which is almost like the endometriotic cavity. Now see that cavity? See that? This is a proper endometriotic cavity, but this is not connecting into the uterus. If you do histoscopy, it's a clean histoscopy and you will find both the ostia very, very clearly. So this, I'm not sure what it is. It could be a congenital anomaly or it could be a cystic endometriosis. But one classical thing is you will always find it below the round ligament. You will not see on the left side. You will always see it on the right side. We have had 4 cases of ACOM. We have always seen it on the right side. You've not seen it on the left side. It will be right below the round ligament. And young patients, of course, you will have severe dysmenorrhea, and you can see that cavity. You need to remove that cavity completely, as you can see here. Then only it gets cured. You keep part of it, it doesn't get cured. We can remove it and then reconstruct the uterus completely as such. So thank you so much for your patient listening.
Wonderful surgeries, Dr. Rahman, and a lot of variety we got to see. Though I personally do not agree with the wedge resection, and I don't think our Indian patient requires. Maybe UAE, they go more for such psychological.
I've not seen Indian patients who suffer adenomyosis just for the fact that they don't want to do hysterectomy.
Because they are not even menstruating, right? After this, so like I think our patients agree to complete hysterectomy or a conservative surgery with menstruation preserved. Anyway, I had two queries, Dr. Rahman. One is, do you believe in uterine artery ligation in these cases to prevent the recurrence?
Adenomyosis?
Yeah.
Not at all. Adenomyosis is not a vascular lesion. See, the basic concept of myoma and adenomyosis are totally different lesions. Adenomyosis destroys all the vascularity of the myometrium. If you cut into adenomyosis, it doesn't bleed. So it's not a vascular disease. That is why I do not agree to two things. One is uterine artery embolization. First of all, never in infertility. And the whole concept of uterine artery embolization is that the emboli will go into the larger vessels, which are there for the myoma, but not for adenomyosis. In infertility, if you do adenomyotic uterine artery embolization, it will damage more of the endometrium rather than the myometrium, because myometrium is least vascular in adenomyosis. And another thing is uterine artery ligation, no benefit. Absolutely no benefit, unlike myomas. See, myomas, if you are doing uterine artery embolization to prevent the recurrence of myomas, especially in large number of multiple myomas, it doesn't prevent the recurrence actually, but it reduces the pace of growth. This is the most important. So you feel that it is preventing recurrence, but it reduces the pace of growth of myomas because the vascularity is reduced.
Yeah.
But endometrial vascularity is preserved after uterine artery ligation, but not useful for adenomyosis.
Thank you. And another thing is that's a technical problem which we face when it's a not anterior wall, not posterior wall adenomyosis, which is main bulk. It is rather lateral, and that too in a lower area. Say you can say ischemic area or lower part of the uterus. Some tips for that, how to excise that?
For lateral adenomyosis is not very common, but cervical, like what you said exactly,
two cases.
Ischemic adenomyosis is not very uncommon. That also you put a central incision and core down laterally. So that what happens is the uterine artery is kept laterally. You're not going to the uterine artery at all. Don't go and put a lateral incision. If you put a lateral incision, you can go and damage the uterine artery. If you put a central incision and core down laterally and excise it completely, it is possible.
And we can't remove as much bulk as we can anteriorly or posteriorly. There would be little less comparatively.
Yeah, it depends. It depends how much you can dissect and do it. But see, adenomyotic surgery is one of the most difficult things which you can do. So it has to be done only if you are very good in reconstructing the uterus. This is very, very important, because don't just wedge adenomyosis and then suture it and go. Never do that. Reconstruct the uterus properly, because you will find a lot of ruptures otherwise. Just closing that wound end to end is not the thing. You have to mostly overlap and close it. Unless your suturing skill is good enough to overlap and close it, do not do adenomyotomies.
And there's a question in the chat box about vasopressin, because it is not very vascular structure, as you said, adenomyosis. Does vasopressin help? How does it help?
Vasopressin helps basically not to reduce bleeding as such. Vasopressin helps in non-staining of the myometrium. See, adenomyosis, one of the most important thing when you do adenomyosis surgery, how do you recognize the adenomyosis and the normal tissue? Number one, the feel of it. That is why we are changing it to knife. The knife will give you a better feel than harmonic scalpel or other instruments, even better than the scissors. Number two, by the look of it. So even if small blood vessels are there and it stains the tissue, you will fail to identify that look of the tissue. You need to understand the tissue. When I did with the knife, you could see very clearly what is adenomyotic tissue, what is the uterine. Uterine tissue will have fibers. Adenomyosis will be a homogeneous mass kind of thing. So you can easily identify that adenomyosis and scoop it out very nicely.
Very correct. Same in endometriosis also, tissue distinction becomes much better with this assessment.
Yes.
One more, do you inject?
Only reducing the bleeding. It's an identification of tissue, correct?
Exactly. And do you believe in injecting or like putting intrauterine methylene blue to differentiate or easy recognition of the endometrium?
We do not, when we see the endometrium, you will understand. Methylene blue you will see only when you open the endometrium. When you open the endometrium, even otherwise you will understand. Better than that is you can see adenomyosis. Sometimes the ultrasound, of course, or an MRI will map the adenomyosis, whether it is anterior or posterior, and you will have a definite idea. Another way is in adenomyosis, you will find that even if it is a posterior adenomyosis, sometimes, it contracts posteriorly. You will have the bulge anteriorly. It's like the octopus. You will have the bulge anteriorly pushing the endometrium anteriorly. So if you put an anterior incision, straight away you will go into the cavity. It's unlike fibroid. Fibroid, if the fibroid is posterior, it will bulge posteriorly. Fibroid is anterior, it will bulge anteriorly. In adenomyosis, even if it is a posterior adenomyosis, it will push the endometrium from back and it will bulge anteriorly and the tubes will be contracting towards the posterior. So it will be difficult to understand. In such cases, what you can do, you can put a sound and perforate the uterus so that you will understand exactly where the endometrium is. Perforate the uterus at the fundus, you can understand exactly where the endometrium is and you have to be very careful about endometrium in adenomyosis. This is very, very important because we have seen Asherman in our own cases, in our initial cases. That's why we are today very careful in doing adenomyomectomy. You have to preserve, even if you are doing less adenomyomectomies, means if you are leaving some tissues, you have to preserve the junctional zone or the basal endometrial vascularity. Basal endometrial vascularity is in the junctional zone. That's why I said preserve junctional zone. The ambiguity is the junctional zone adenomyosis is what actually causes infertility. That we cannot remove surgically. If you remove junctional zone adenomyosis, you are producing additions. So
yeah, one more thing, which cases would you like to go for open surgery rather than minimally invasive?
No, I am comfortable with minimally invasive. But there are good minimally invasive surgeons who are telling that open surgery is better for adenomyomectomy. See, there are minimally invasive surgeons who does even radical surgeries, telling that open surgery is little better for adenomyomectomy, basically because they can feel that adenomyosis. Adenomyosis has a different feel. In laparoscopy, you will not get that feel of fingers. So that is why we are shifting towards knife adenomyomectomy, where I saw that I could feel it much better and see it much better and cut it so that I can remove each and every piece. So personally, I don't find an indication for doing an open adenomyomectomy.
Even 24 week size uterus, 26 weeks, like we had such cases.
Okay.
I thought.
But whether I will recommend it for me, whatever size, it's fine. But whether I will recommend it normally for everybody is a different question. It all depends on each person's skill and the setup and all those things. See, our setups are like a fantastic setup we have. Even today we were doing a nephrectomy also. So we have a good setup and we have achieved that kind of a surgical skill. But whether I should recommend doing an open laparoscopic myomectomy for all 24 weeks, I may not. Depends on your skill. If you have achieved that skill, you can do it. But there is nothing wrong in doing an open adenomyomectomy. Like 24.
Wonderful talk, sir. Nice presentation and awesome presentation, sir. And I just wanted to ask, sir, after doing the surgery, like how much time do you wait? Like how much time you give the contraception? 3 months, 6 months? Or do you see the blood flow of the uterus and then you let the patient conceive? What is your
ideally, we have to wait at least 6 months. See, there are two reasons why we are waiting 6 months. One is to get the complete scar integrity. The scar has to heal. It's not just healing. If it is a myomectomy, we will wait for 3 to 4 months. But if it is an adenomyomectomy, we wait for scar healing and integrity. These are two things. The scar gets completely closed only after 6 months, around 6 months. And another thing is, See, adenomyoectomy we are not removing the complete adenomyosis, nor we are treating the ectopic endometrial abnormalities. So during the 6 months, you can give medical treatment combined with the surgical treatment, which will be very good as far as infertility is concerned. And the endometrial treatment also is done. So the ectopic endometrium will become much better. As Dr. Jyoti was telling, if you look at the endometrium, estrogen levels in the endometrium, there's a high estrogen level in endometrium of adenomyosis patients, basically because of the cytochrome 450 activity, which is quite high in these adenomyosis patients. So you have a very high estrogen level. So these things can be treated during the 6 months with the medical treatment as such. So a combination of these two, I think they can give you a good result.
Okay, thank you, sir. You have beautifully covered all the points. So I just want to highlight a few points, like this is the surgery which has to be done by the expert. There's no doubt. And whenever we are doing any kind of surgical intervention, we should thoroughly explore the abdomen and the pelvic cavity, because the endometriosis, which is commonly associated, may lead to the incomplete surgery and the risk of reoperation also. And then secondly is the adenomyosis. The tissue is quite hard. And then to get a good boundary between the lesion and the normal tissue actually is by the palpation. So like we should not be hesitant in opening up the patient or doing a lap assisted surgeries. We should not be determined only on laparoscopic surgeries, because if we do incomplete surgery, then the suturing also is very difficult. And the good approximation also is not there. And if good approximation is not there, then the reconstruction is not good, then it will lead to the leaks, and then the uterine rupture chances are very high. The next point is that regarding which instrument we should prefer, like certainly we should avoid the cautery at these places, but or the minimum use of cautery if at all. But the studies, they say now laser has come up now. It has a good role, like the lateral damage is very less. So that is one option, but the data regarding which instrument to use, there is no clear-cut data regarding it. And then about the contraception period, as you said, sir, for 6 months, like a few studies, they are saying that we can look upon the uterine blood flow, and we can induce the patient before or afterward also. So those are the few points I think is important. And thank you, sir. It was a very nice talk, and it was really a visual treat to all of us.
Thank you very much. Thank you, chairpersons, for your inputs. Thank you, Dr. Dinesh, Dr. Richa, for your practical points, and the living legend of endoscopy, Dr. Hafiz Rahman, sir. I mean, every time we see your surgeries, we feel we are all mesmerized seeing your surgical skills, and the practical points that you always add on to those surgical points is enormous. And definitely things like a cervical adenomyosis, which is very less spoken of. So we half of us never ever even knew that it exists. So this is something that you have shown to us. We still have 102 participants. Thank you so very much for keeping still with us. It's nearly 3 hours that you have all logged in. And thank you very much. Anything you would like to add, Dr. Asha, ma'am?
I just wanted to say that I really enjoyed this talk by Dr. Hafiz Rahman. It was really a very vivid presentation. We have been watching his surgeries over, I think, more than 30 years, Dr. Hafiz. I remember Professor Rajan saying that, give a big hand to this young man who has done so many hysterectomies in India. And this must be, 1990. So over 30 years, we have been watching Dr. Hafiz, and I have really enjoyed this talk, Hafiz. Wonderful talk. But I love this comment from Richa that everybody is not Dr. Hafiz. So many of us can still do an open surgery. Sun et al. Have said about laparoscopy plus laparotomy. Osada also says the same. For focal adenomyosis, do a laparoscopic surgery, whereas a diffuse adenomyosis, you can do a good surgery because it's an extensive surgery. Maybe it is safer to do open surgery when you are not Hafiz Rahman. So, and thank you, Jyoti, for that wonderful session. We have really enjoyed this.
Dr. Jyoti, it was so wonderfully organized by you. The participants were more than 200. Earlier, I think 220. And like only you can manage such a show. Great speakers and great faculty. Really enjoyed it.
Yes. My pleasure. That is so kind of you to say that, Dr. Dinesh. It was pleasure having each one of you. Over to Dr. Shashi for thanking each one present.
Thank you, Dr. Jyoti. I take this opportunity to give thanks to our beloved Dr. Ragini ma'am, VP Foxy, who spared her valuable time. Dr. Lakshmi Sikhande, President ISOPAR Vidarbh Chapter. Dr. Achala Batra, President-elect AOGD, for giving the valuable time. And thank you, Dr. Jyoti, the charming lady, who was instrumental in organizing this whole show. And my sincere thanks to all the speakers, Dr. Ashok Khurana, Dr. Asha Rao, Dr. Jyoti herself, and Dr. Hafiz Rahman. It was a wonderful talk, and the presentations were awesome by everybody. And they are the masters of their subject. And my sincere thanks to all the chairpersons, Dr. Nanda, Dr. Mala Srivastava ma'am, President AOGD, Dr. Kanti Bansal, Dr. KG Nair, Dr. Dinesh Kanchal ma'am, and Dr. Richa. And Dr. Richa also did a wonderful job. She was also instrumental in organizing this show with Dr. Jyoti. Thank you, everybody, and thank you, Tablet India.
Yeah, thanks.
Without you,
thank you so much. Thank you, everybody. Well done, Dr. Jyoti. Congratulations. It was really a successful webinar.
Yeah,
thank you.
Very successful webinar.
Dr. Shashi and Dr. Richa, because in your committees, it was a wonderful show. And Dr. Ragini was here till now. Thank you, Dr. Ragini, for continuing with us for so long. I think she is just now left because she was here right till the end. So a wonderful.
Nanda also is here till now, sir. Thank you so much. Sir.
Yeah.
It was a wonderful talk. Thank you.
Thank you.
Wonderful session.
It was wonderful.
Yeah, Dr. Ragini
of masters only.
Dr. Ragini is here. Thank you, ma'am. Dr. Ragini, ma'am.
First in till end, and Dr. Hafiz is as usual is amazing. And you have spoken very well. Very well, Jyoti. Wonderful.
Thank you, ma'am. Thank you, everybody, and thank you, tablets, so that for your support. And we look forward to many such webinars. Thank you, the faculty and the participants. Thank you. Have a fruitful, prosperous, healthy, and a happy new year ahead. Thank you. Bye-bye.
Thank you.
Nice meeting.
Thank you, ma'am.
everybody
With your permission,
platform.
we are closing this session.
Sure. Thank you.
Thank you, ma'am.